We are like,
Hello, good evening, everyone. It's a pleasure to welcome you all for this series of webinar and excellent topics which has been discussed with the clinical management of common cancers, the newer perspective. I think the last 2 week has been wonderful. Yesterday, great discussions on head and neck and ovarian cancer. Today, I think this is the closing day, but the kind of topic which has been selected on lung cancers are very good. And before we start, it's again pleasure. So thank you everyone who has joined us and people who are joining us now. We have a pleasure to welcome and invite. Hello. So we have a pleasure and welcome invite Dr. Tarajan Gupta sir, who is the consultant medical oncologist at the prestigious Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. So thank you so much once again. Good evening, Dr. Tarajan sir. Over to you for your welcome and introduction and taking the proceedings further, please. Over to you.
Thank you, Tarunji and Rajan. Dear friends and colleagues, it's our great pleasure to warmly welcome you to be a part of our virtual conference, Clinical Management of Common Cancer New Perspective, that is being run since last week on the weekends, usually 4th and 5th November, and then yesterday also 11th November. Today is the last day of this virtual conference, but not least it is the 12th November 2022. So today we have selected the topic for the conference is the lung cancer. To improve the knowledge and competence of the lung cancer treatment and participants to apply the practice-changing clinical data and expert recommendation to optimize clinical outcomes for patients receiving therapy in this cancer. So we expect from our experts are likely to help physicians and practitioners. They will put the role of multiple therapies in a clinical context and discuss how they can effectively contribute to the patient care. Lung cancer is a very vast topic, but yes, we will try to cover up and so that we can update our practice also, our knowledge also, and we can pass on the maximum benefit to the patient so that they can get the best treatment and the best results. So this conference is being organized under the aegis of Prime Oncology Society Raipur and supported by the CRST Foundation. So now, without being much delay, I invite Dr. Abhinav Jawar, who is a consultant medical oncologist in Aurangabad. He will be speaking on the role of maintenance post CTRT in lung cancer. Dr. Abhinav Jawar, over to you, please.
Thank you, sir. Yeah. Good evening, everyone. My slides are visible?
Yes, sir.
Yes. Good evening, everyone. I'm Dr. Abhinav Jawar. I'm a medical oncologist at Kamal Nayan Bajaj Hospital, Aurangabad. I thank all the organizers and especially Tara Chand sir for inviting me as a speaker. Thank you, sir. And now I'll discuss about the role of maintenance treatment in post-CTRT in NSCLC. So basically, management of unresectable stage 3 NSCLC, there have been no much of improvement. And I think that is where a role of any addition of therapy has come up in a big way. So basically, unresectable stage 3 is basically N2, N3 disease, wherein you need a multidisciplinary team which determines the resectability and the treatment part. A T4N0 may, if not resectable, we need to plan for some kind of a definitive therapy. Here comes the role of a pathologist, radiation, medical oncologist, pulmonologist, and a thoracic surgeon. Pre-treatment evaluation will be requiring pulmonary function test, bronchoscopy, PET-CT scan, pathological mediastinal lymph node evaluation, brain MRI with contrast. The current standard of care is definitive chemoradiation, and it is better, concurrent is better than sequential chemoradiation. Now, the chemotherapy regimens used with radiotherapy in NSCLC have been cis-etopo, cisplatin, vinblastine, pemetrexed, cisplatin. So coming to the or paclitaxel carboplatin, overall the OS has been in the to the tune of overall, the median OS have been to the tune of 22 to 25 months on an average, and the PFS has been in the range of in most of them it's not reached, but it is to the tune of 1 year. So as we can see, the median OS is maximum with cisplatin etoposide, which is the standard we follow, or pemetrexed cisplatin 26.8 months. Now coming to the sequential regimens, the median OS is definitely less, 14.6. But if sometimes patient is not fit, yes, we do use sequential regimens, mainly pemetrexed cisplatin or cis etopo. That also can be used in sequential regimen. Now coming to the unmet needs in stage 3. So what we have seen is post chemo radiation with curative intent, a median PFS is in the range of 8 to 12 months, and the 5-year overall survival is 15 to 25%, which is quite less. And most of them have, like, it's almost 50% will have distant metastasis, and 40% develop locoregional metastasis. So the various trials which have been conducted to evaluate the consolidation therapy, none of them has shown neither PFS or OS benefit. There is no phase 3 study of consolidation with chemotherapy, targeted therapy, or vaccines which have demonstrated PFS or OS benefit in patients with unresectable locally advanced NSCLC. So this has been the treatment evolution of stage 3 unresectable NSCLC. If we look at this, this is where we are standing currently. And it started with radiotherapy, initially sequential chemoradiation versus RT. Radiation definitely had shown a benefit. Then came the role of sequential chemoradiation, which showed a OS benefit. It changed, and we shifted from concurrent chemoradiation, which also showed a 3-year OS benefit of 16 versus 2%. But later on, we have not achieved any OS benefit. If we compare it concurrent chemoradiation, then induction chemotherapy followed by chemoradiation, no OS benefit. Neither consolidation chemotherapy have shown any OS benefit. Although there is in 2021 in JAMA, we had a published paper on pembrolizumab addition to chemotherapy, but that has shown that is a phase 2 study which has shown promising results for. But we need to have more of phase 3 study for using immunotherapy with chemoradiation, but that is that will take some time. So basically, currently we don't have much to improve. So, but then came the immunotherapy. So currently, chemoradiation is the standard of therapy with good PFS. If not fit, sequential chemoradiation remains an option. To improve the prognosis, further strategies like increasing the radiation dose, induction chemotherapy, and consolidation were evaluated, but there has been no improvement. Immunotherapy is being recognized as a safe and effective option as an adjunct to chemoradiation. Now, the rationale for PD-L1 inhibitor following chemoradiation. So chemoradiation basically has direct cytotoxic effects, and plus it induces the immunomodulatory changes. So it causes increase in the antigen release from the dying tumor cells, upregulation of the PD-L1, and immunomodulatory. Because of the cell death, there is more of antigenic release, which is macrophages take it, and then which is shown leading to upregulation of PD-L1, upregulation of the immunogenic cell surface markers, increased secretion of cytokine. So durvalumab, how does it act? Basically, durvalumab is an anti-PD-L1 antibody. So it blocks the PD-L1 mediated inhibitory signal, which is the tumor cell is giving an inhibitory signal through PD-L1, and durvalumab is the inhibitor which inhibits the PD-L1 inhibitory activity, leading to enhanced T cell function and thus leading to control in the disease. So radiation and immunotherapy, what are the expected outcome? So could help with micrometastatic disease, because radiation also leads to abscopal effect. Basically, it's an immune mediated response to the radiation by the tumor cells which are located at distant site from the irradiated site. It can have local treatment effect, reducing the local failure, and it can also it is immunotherapy is a systemic therapy. Yeah, so it might help in the distant failure rate, decreasing the distant failure rate. So that was the underlying reason the Pacific study chose durvalumab as a study. And phase 3, it was a phase 3 randomized double-blind placebo-controlled multi-center international study in which patients with stage 3 locally advanced unresectable NACLC who have not progressed following definitive platinum-based chemoradiation, 18 years or older, with a PS of 0 or 1, with an expected life expectancy of at least 12 weeks, and archived tissues were collected. All comers were there in the population, and they were randomized into 2:1 arm, with durvalumab being given at 10 milligram per kg every 2 weeks for up to a year, and placebo was given for up to a year. And it was given within at least 1 to 42 days post chemoradiation. So the co-primary endpoints were PFS and OS, and the key secondary endpoints were overall response rate and DOR and safety and tolerability. So the patient, as we can see, the baseline characteristics were equally matched in both the arms. Almost the age group, if we can see, it is approximately 65 years. Male patients were 70% of them were male patient with Asian. Now, if you look at the Asian cohort, it was approximately 25% Asian representation was there in the study, and 50% were stage 3, 3B were 44, approximately 50%, and almost everywhere and the PS was 0 were 50%, PS1 were 50%. If you look at the EGFR status, we can see that 6.1% of the patients were EGFR positive, but and almost two-third majority were EGFR negative, and unknown were seen in 30% of the patient. So coming to the PDL1, which is the important part, PDL1, if you look at the PDL1 expression, so it was in less than 25%, like 40% were less than 25%, and more than 25%, it was approximately 1/4, and unknown in 36%. Majority were smokers, and the histology being almost equal, squamous, non-squamous cell 50-50%, and radiation was given 54 to 66 grade. So now, but if you look at this, almost 25% of the patient had received induction chemotherapy, both in the placebo versus the durvalumab. So that is one important thing, that 25% had received some kind of induction chemotherapy. Now, all patients Pacific study prior to chemoradiation and baseline, so almost 711 patients received concurrent CTRT, and prior to study, almost 191 patients had that, which is 1/4 of the patient had received some kind of induction chemotherapy prior to the start of the study. So now coming to the overall survival, 5-year OS survival. So it was almost, if you look at the curves are nicely separating, it is at 5 years, it was 42.5, 42.9 and 33.4% at 5-year survival, OS survival, with a almost median OS being 47.5 and 29.1 in the placebo arm, with a hazard ratio being 0.72. So if you look, this is the first and only approved IO to demonstrate 42.9% OS at 5 years. And the PFS, similarly, the PFS curves are nicely separating from each other, with a median OS of 16.9 versus 5.6 with a HR of 0.55. So the first and only approved IO to show sustained and durable PFS of 33.1% benefit at 5 years compared to 19% with the placebo arm. So first subsequent therapy after discontinuation of durvalumab. If we in durvalumab arm, 41% and approximately 54% had received some kind of subsequent disease-related anti-cancer therapy. So systemic therapies were administered with or without radiation, with the most common first subsequent anti-cancer therapy in both the arms, durvalumab and the placebo. So overall, almost 50% of the patient received subsequent therapy.
Sorry, Abhinav, last 2 minutes, please.
Yes, sir. So the pattern of progression also, if you look at the disease progression by location, the both intrathoracic progression was the most common in the durvalumab arm versus the placebo arm. And it had improved both the intrathoracic progression compared to the placebo. And if you look at the pattern of progression in the extrathoracic, that has also shown a definite improvement in the extrathoracic arm progression. The safety wise, both the placebo and the durvalumab, it is quite the toxicity profile, it is quite manageable and not much of toxicities. Now the time to start to durvalumab after chemoradiation. So if we look at the real world data from this, so there is a phase 3 study which was done at France. There were 591 patients were enrolled, out of which 561 were included. Almost the same the baseline characteristics in both the Pacific and the France, the study done at farms, it was almost equal, comparable. But if you look at this, in almost 40% of the patient, durvalumab was started 42 days prior to post chemoradiation. So almost comparable result we can see in both durvalumab and the in the Pacific study versus the study done at France. So the response were like what was observed in Pacific study, despite almost 40% starting durvalumab 42 days post chemoradiation. So there is a 5-year survival is important endpoint. Optimal chemoradiation IO should be the standard of care in all stage 3 and stage 3 cancers, and converting stage 3 lung cancer into never progressing disease. So the survival at 5 years, so looking back to the future, if you look at it, survival at 5 years is becoming the important endpoint as for NSCLC, and it might become a chronic oncological disease. So the key takeaway from this study was the median OS was 47.5 months for durvalumab versus 29.1 for placebo. The PFS definitely doubled, 16.9 versus 5.6. The OS PFS improvement with durvalumab was demonstrated across all pre-specified subgroups. The 5-year OS is 43%, and almost a third of them are both alive and free of disease progression with the durvalumab arm. In the durvalumab arm, and patients receiving durvalumab had a lower incidence of new lesions, both intrathoracic, extrathoracic. Tolerability is acceptable. Low-grade pneumonitis should not be a deterrent to use durvalumab. And the French study also shows that durvalumab starting post 42 days showed similar response to the one which we have observed in Pacific study. Thank you. Thank you, sir.
Thank you, Abhinav, for a elaborated presentation. Wonderful, and explaining the role of maintenance CTRT. Now I invite Dr. Lalit Sharma, who is a consultant medical oncologist, Manipal Hospital, Jaipur. Will be speaking in the AstraZeneca sponsored session, osimertinib as adjuvant therapy in patients with resected EGFR mutated stage 1B to 3 in NSCLC. The updated results from ADAURA. So, Lalit, over to you, please. Lalit, you are muted.
Sorry. Thank you, Dr. Tara, for the invitation. Thank you, Astra, for the opportunity. So the topic for today's discussion, which has been allotted to me, is early non-small cell lung carcinoma. I'm not able to share my screen. Okay, now, is my screen visible?
Yes, sir.
Okay, so the topic allotted to me today is role of osimertinib in early stage non-small cell lung carcinoma. Non-small cell lung carcinoma is one disorder where in the last decade or so, we have seen a drastic change from where we have moved away from treating lung carcinoma as a garden variety of cancer to the core personalization of therapy, wherein we are looking for molecular markers which are deriving particular tumors, targeting those molecular markers, and achieving great success in improving not only just overall survivals, but the quality of life of the patients also. So most of the paradigm shift which we have seen in non-small cell lung carcinomas, especially EGFR mutated ones, has been in the metastatic setting. And as does happen with most of the molecules and most of the oncological disorders, we gradually try to translate that advantage of blocking these specific targets to the early stage cancers also. So the investigators tried to do the same with osimertinib in the multi-center phase 3 ADAURA trial. And the ADAURA basically had inclusion criteria of patients who were adult with good performance score and had confirmed primary non-squamous non-small cell lung carcinoma. Patients needed to be EGFR positive, be it 19 deletion positivity or L858R positivity. Brain imaging was done, and if not completed preoperatively, complete resection with negative margins was required. Uh, Maximum interval between surgery and randomization was 10 weeks without adjuvant chemotherapy and 26 weeks with adjuvant chemotherapy. Stratification was done on the basis of stage, be it early stage such as 1B or 2 versus 3A. EGFR mutation stratification in the form of exon 19 deletion versus 6858R mutation, and Asian versus non-Asian mutation. The experimental arm received osimertinib 80 milligram per day, vis-a-vis the observational arm which received placebo once daily. The planned duration for the treatment was 3 years, and the treatment was continued until disease recurrence or treatment completed, discontinuation on criteria which were met. So the follow-up was done until recurrence or week 12 and 24, then every 24 weeks up to 5 years, and then yearly. After recurrence, every 24 weeks for 5 years, and then yearly. The primary endpoint was kept to be disease-free survival by the investigators, assessment in the stage 2 and 3A patients, and designed for superiority under the assumed DFS hazard ratio of 0.70. The secondary endpoints were DFS in the overall population, DFS as 2, 3, 4, and 5 years, overall survival, safety data, and the health-related quality of life. The pre-specified exploratory endpoints were patterns of recurrence, time to CNS disease, and recurrence of the disease in the non-CNS. Now, as far as the demographics of the patients were concerned, both the arms seemed pretty well matched, be it for gender, age, smoking history, or ethnicity. Patients were pretty well matched in both the arms for the stage of the disease also, and for the various EGFR mutations, be it exon 19 deletion or L858R. Now, at analysis, the disease-free survival benefit with adjuvant osimertinib was pretty evident, and it was very robust. At the primary analysis showed a highly statistically significant and clinically meaningful improvement in the DFS with adjuvant osimertinib versus the placebo, wherein the disease-free survival with osimertinib, the graphs are pretty widely separated. The hazard ratio is very impressive of 0.17, though the non-superiority could have been confirmed at 0.7, but to the surprise of all of us, the benefit magnitude was way beyond that. And an updated analysis of final DFS, the primary endpoint, also showed that the benefit was pretty well maintained, with a median DFS of 65.8 months with osimertinib vis-a-vis the placebo arm having only a DFS of 21.9 months, with a hazard ratio of 0.23. This benefit was seen across all pre-specified subgroups, though there was a tendency towards more benefit in patients who were early smokers and more benefit in the non-Asian population. There was also a difference as per the stage of the disease, and as the stage of the disease was more advanced, the advantage was even better as compared to the early stage disease. If we talk about the EGFR mutation, the exon 19 deletion derived more benefit as compared to L858R. Patients who had received adjuvant chemotherapy also derived more benefit as compared to patients who did not receive adjuvant chemotherapy. The updated DFS by stage showed that the magnitude of the benefit was more as the stage of the disease advanced. As we can very well see in this particular slide, that the graphs are further widely separating as the the stage of the disease is progressing. So even in the stage 3A, the most advanced setting, the graphs are pretty well widely separated. So the benefit was kind of maintained even on evaluation of AGCC 8th edition, which was the change which occurred during the study period. The pattern of disease recurrence were more or less similar as compared to the patients in the placebo, though the magnitude was pretty less. The most common site of recurrence in both the arms was in the lung, followed by lymph nodes, and followed by CNS. But a very important thing to be noticed here is that the CNS recurrence rate was reduced pretty drastically by osimertinib. So overall, 63 patients had CNS DFS events, but only, and amongst these, around 32 patients were still on the treatment, but only 3 of them were on osimertinib, and rest of them all on placebo. So both the CNS and non-CNS recurrence rates were reduced by osimertinib in this adjuvant setting. The safety analysis also did tell us that this advantage came at a cost of some additional toxicity. All adverse events were slightly more in the osimertinib arm, especially talking about the adverse events leading to severe adverse events leading to dose discontinuation, be it dose reduction or interruption. All were more common in the osimertinib arm. The most common side effects which were seen were in the form of diarrhea, paronychia, dry skin, and pruritus. They were all to a larger magnitude in the osimertinib arm, but grade 3, 4, or very severe if adverse events were not that common. Another adverse event which was seen was interstitial lung disease and QTc prolongation, which were more common with the osimertinib arm as compared to the placebo arm. So to conclude this updated DFS analysis of osimertinib in patients who were followed for further 2 years and all had the opportunity to complete 3 years of planned study treatment, shows us that overall there is a 77% reduction in the risk of the disease recurrence or death with adjuvant osimertinib versus placebo, with a hazard ratio of 0.23 in the patients with stage 2 and 3A population. The median DFS was 65.8 months with the osimertinib arm versus 21.9 months in the placebo arm. There was also a 73% reduction in the risk of the disease recurrence or death with adjuvant osimertinib as compared to placebo. An improvement in the DFS was also seen regardless of whether patient had received prior adjuvant chemotherapy or not. And the DFS benefit was seen across all stages of the disease and was actually more in the patients who had advanced stage diseases. Osimertinib demonstrated a clinically meaningful improvement in the CNS disease-free survival also, and hence the prevention from the morbidity out of the CNS recurrence. The safety profile was consistent with the established safety profile of osimertinib, and no new safety concerns were reported with an extended treatment duration. Median total duration of exposure to osimertinib was around 35.8 months in this particular study. Now, these updated data reinforce the adjuvant osimertinib as the standard of care for patients with EGFR mutated stage 1B through 3A non-small cell lung carcinoma after completion of tumor resection with or without the adjuvant chemotherapy. Thank you. Thank you so much for a patient hearing.
So, Dr. Lalit, what is your choice of in a resected EGFR? Are you ready to use osimertinib or not? And and also the after the chemotherapy or directly without chemotherapy?
Well, I would definitely consider adjuvant chemotherapy, and I would also be tempted with using osimertinib in these patients.
So you will use after the chemotherapy osimertinib or directly after the resection without giving the chemotherapy?
No, after adjuvant chemotherapy.
After the adjuvant, and how many cycles will you give after the adjuvant, and which chemotherapy regimen will be of your preference?
Well, it depends on whether we have used in a sequential manner or we had gone for whether a new adjuvant approach was used. Most of these cases would be kind of resected first, and then probably 4 cycles of adjuvant chemotherapy followed by adjuvant osimertinib, and these 4 cycles would be my choice. Would be most of these patients being adenocarcinoma pan-carbo.
Okay, so you will use in all patients if the patients are affording and EGFR mutant, right?
Yeah.
After. Thank you, Lalit. For the next talk, I invite Dr. Amit Kumar, Senior Consultant, Medical Oncology and Hemato-Oncology, Medanta Hospital, Patna. He will be speaking on first-line EGFR TKI in non-T790M, dacometinib versus osimertinib. Amit Kumar, over to you.
So, good evening, everyone, and thanks, Dr. Tarachand, for this opportunity. So, I'm just discussing about the first-line therapy in EGFR mutated lung cancer, especially in perspective to osimertinib or dacometinib in this group of patients. So, I will just be discussing about the efficacy, side effects, and how to select a patient, whether to go for osimertinib or dacometinib. So just having an overview of this, so EGFR mutation is seen in something around 40 to 40% of the patient, and in the Asian population, this is something around, as we know, it is 20 to 23%, depending on the different institutes. And out of these, the most common is exon 19 deletion, and the other being exon 21 L858R mutation in this group of patients. So what we see is the regarding the generations, that the first generation, second generation, and third generation of the drugs. So gefitinib and erlotinib, which were the first generation, has an activity range involving wild type EGFR and the intrinsic mutation EGFR. So they are affecting both this, both EGFR of the wild type and the intrinsic mutant EGFR. Whereas the afatinib or dacometinib, which is the second generation, has a further activity which is going to affect the HER2 and HER4 mutations, along with the wild type and intrinsic mutant EGFR. Whereas the osimertinib, which is a very selective inhibitor, it is found to be affecting only the intrinsic mutant EGFR and the acquired T790M mutation, whereas it is not affecting the wild type 1 and the HER2, HER3, so might be the side effect profile being low with this agent. So what we are seeing in the different clinical trials is in the first line NSCLC is from the first generation to second and third generation, the overall survival is found to be increasing along with the PFS in this group of patients. So with the third generation, now the OS is going up to 38.6 months with the PFS of something around 18 months, whereas the second generation going up to 14.7 with dacometinib and 11 months with afatinib. So coming to the dacometinib study, the Archer 1050 study design, which has included the treatment naive patients without any CNS mets with 45 milligram of dacometinib along with gefitinib of 250 milligram. So these patients have got a median PFS, what we say with dacometinib is around 16.6 months as compared to gefitinib of 11 months. So there's a definite benefit in the median PFS in this group of patients. So OS was found to be longer in the also in the dacometinib arm as compared to the gefitinib arm. And what we see is that the OS median something is going around 34 months with dacometinib as compared to only 27 months in the as compared to gefitinib with the second line involving other studies. And what we see is regarding though this study hasn't included any patient with the brain mets, but in the serial, it has been seen that the only one patient in the dacometinib group has progressed to the brain as compared to 11 patients in this gefitinib group. What we see is it is more important, more active in the case of exon 21 L858R mutation as compared to the exon 19 deletion mutation. So the hazard rate for what we say for exon 19 deletion, since what we say biologically, this is so sensitive that all the TKIs are being effective in exon 19 deletion, and so further improvement might not be possible in this group of patients. But as in case of the exon 21 L858R mutation, in which the gefitinib works poorly, in that case, the dacometinib is found to have a much better outcome, with a median OS going something around 32 months as compared to gefitinib, which is around only 23 months in this group of patients. So maintained benefit of dacometinib over gefitinib in terms of PFS and OS in patients, if we have seen those who have undergone dose reduction also. So what we have seen, if the patient have undergone dose reduction, those patients also the median OS is better, something around 42.5 months versus 34 months as compared to those who don't have the dose reduction. So, and the more frequent side effect profiles, as you know, is with dacometinib are diarrhea, paronychia, dermatitis, and stomatitis, as compared to the dose of gefitinib, in which diarrhea is only in 55%, whereas in dacometinib it is going up to the 88% in this group of patients. So with the safety wise that we see, even if the dose has been reduced, and most patients, as we say, has undergone a dose reduction, something around 67% of the patient has got a dose reduction in the dacometinib arm, but still the efficacy is maintained in this group of patients. And even if the patient has been switched to the next treatment, so subsequent treatment, as we say, something around 57% in the dacometinib arm has received the subsequent treatment as compared to 65% in the gefitinib arm. But what we say, only 10% of the subsequent treatment is of the EGFR TKIs in this group of patients. So the next drug, which is the third generation one, that is the osimertinib, in which what we see is the FLORA double-blinded study design. It shows that the overall survival, they have taken basically all the patients with exon 19 or deletion, but they have also included a stable CNS mets in these group of patients. And osimertinib has been compared with gefitinib or erlotinib in this group of patients. So the PFS, as we say, is the median PFS of something around 19 months with the osimertinib as compared to only 10 months with the other EGFR TKIs. And this is found to be much more better in the case of non-Asians, as we say, in the CNS disease also, this has a hold its benefit, along with those of the EGFR mutations patients, both with the exon 19 or L858R, has found to be showing its benefit. So the overall survival, if we say, if the patient has been even started on gefitinib or erlotinib and they have switched to osimertinib, they have been allowed to switch in those group of patients, crossover is allowed, and the initial patients who have only started on osimertinib. So if what is seen is that there's 20% lower risk of death, even if in the presence of crossover from the comparator group to osimertinib in this group of patients. So there is a definite benefit if you are starting upfront osimertinib as compared to starting with the first line and then switching over to osimertinib in the next line. With the median OS is something around 38.6 months versus 32 months. So as a secondary endpoint, what we see, the trial group, so the Asian subgroup of patients were not powered for overall survival analysis in any of the groups, but what we see, especially in the case of the L858R mutation, the maximum benefit is being seen with dacometinib, and osimertinib also fares well in this group of patients. But it is mostly, as we say, the median OS is something, PFS is 12.3 months with dacometinib, and with osimertinib is 14.4 months for L858R group. But for exon 19 deletion, surely there's a definite benefit with osimertinib going to 21 months as compared to the all other first or second generation drugs. So in the osimertinib arm, nearly 50% of the patients receive first subsequent therapy, and nearly 70% of these 50% have got received a chemotherapy. Where in the first generation EGFR TKI arm, something around 30% of these patients have received osimertinib. So 50% in most arms have somehow gone to the subsequent therapy. So both arms fares well in that way. The toxicity wise, osimertinib, as you know, is a much more safer drug with the most commonly reported toxicities as rash, acne, diarrhea, and dry skin. Whereas the adverse event of grade 3 or higher is something we say is 42% in the case of osimertinib group and 47% in the comparator group. And rate of treatment discontinuation is more or less same in both the groups. So the NCCN also suggests what we say osimertinib as a category 1, dacometinib 2 is being recommended as a category 1. So it's the preferential choice how to separate between both this second or the third generation. So which drug you have to choose for? There are more questions. So as there is a lack of a randomized trial comparing surely a second generation versus a third generation DKI, the comparison is with the first generation only. Longer follow-up of already completed phase 3 trials still is not adding much to this information. So how to sequencing the drug with second generation followed by third versus upfront third is one question which has to be answered. And what are the results of the bispecific antibodies after progression on all generation have further effects. So how do you going to decide which drug to be given as a first line agent? So it all depends on the performance status of the patient, age, comorbidities, and drug interaction. Along with this, the cost of the therapy, which is the most important thing which is affecting the tolerability to the drug, the systemic anti-tumor activity, impact use of subsequent anti-cancer therapies, and which drug is has a CNS activity. So you have to have a personalized approach in this case to decide which drug is to be given first. So if we see that systemic anti-tumor activity and impact on the subsequent anti-cancer therapies has to be checked. So with the dacometinib, the PFS is and OS goes something around 34 months as compared to osimertinib, which is 38.6 months. So if you start with the second generation and then switch off to with the based on the mutation of T790 and to the third generation, followed by chemotherapy, or a third generation followed by chemo. So in both cases, only what we see 10% of the patient can receive a third generation EGFR TKI if you are given a second generation one. So it has to be decided based on that. Regarding CNS activity, so surely in the case of the afatinib, the patient with CNS mets have included, but in the dacometinib trial, it has been excluded. In the osimertinib, true, FLORA, it has been included. So what we see is the patient is a CNS mets, and in that case, the osimertinib works much better with 15.2 months versus 9.6 with the first generation. So progression-free survival at 18 months among patients with CNS mets is something around 58% in the osimertinib group versus 40% in the comparator group. For leptomeningeal, there is one question that what dose of osimertinib? Surely one may go for a double dosing of osimertinib in subtypes. So you have to decide depending on the patient's general status. So regarding the what we say the tolerability, so dose reduction is only required in 4% of the cases of osimertinib, as compared to something around we say 67% in the cases of dacometinib, where the dose reduction is needed, and in afatinib around 42% of patients requires a dose reduction. And treatment discontinuation rate is though due to adverse more or less same, but dose reduction is a factor which occurs in most cases of dacometinib. So one needs to carefully to handle this drug. So there are few things which you have to take in consideration while prescribing osimertinib or dacometinib. That if you are using a PPI, so osimertinib don't have any interaction, but dacometinib you have to avoid this use with drugs like hydroxychloroquine. So there is no interaction with dacometinib, but osimertinib increases QTC. So you have to take this. With ATT, more interaction with osimertinib as compared to dacometinib, where there is no significant interaction. Relationship with food is with or without food. Cardiac dysfunction needs more frequent monitoring. Uncommon mutations, as we say, afatinib is the only EGFR TKI which is approved for the uncommon mutation, whereas the osimertinib is also being approved for a few major uncommon mutations. But for dacometinib, it is what we say is that further data is needed for confirmation of the activity, which seems to have some benefit. So regarding toxicity management, surely one knows that what are the interstitial lung disease, diarrhea, dermatological adverse event, and how to manage this, not going into details. So you have other important clinical points like pregnancy, if you know when to start something around, you have to use effective contraceptions. For geriatric, a high dose reduction is needed in dacometinib. Renal impairment, recommended dose has not been established for severe renal impairment. And for liver impairment, no dose adjustment for dacometinib are there. Osimertinib toxicity management, one has to know that if there's an interstitial lung disease in this group of patients, you have to permanently discontinue this drug. But for other like QTC interval or prolongation or some then you have to withhold it. For congestive heart failure, you have to discontinue this drug. So you have to look for all these toxicity profile while acting this drug. So with osimertinib, important thing is cardiac monitoring has to be done with this drug for pregnancy to avoid use effective contraception. Geriatric, this drug is well tolerable, as we say. Renal and hepatic, no recommended dose in this group of patients. And this tablet can also be taken if you are giving through rice tube. If you can disperse in water, non-carbonated water you can give. So further, you have to educate the patient regarding how to take care of the skin, what are the dietary modification, what are the general precautions, and what are the medications to take in the case of diarrhea happening in this group of patients, and the other danger signs. So what we to say, so you have to choose based on the patient. Obviously, from my perspective, it is the osimertinib is always the first one, but surely dacometinib too have a role, especially if the patient have an exon 21A58R mutation. So you can start with dacometinib and then switch to the next generation in this group of patients. With this, I'd like to end. Thanks.
Thank you, Amit. And so now I think you are also clear that which agent you will use if the T790M is there.
Surely.
So you are sure that you will use which agent you will use?
What if there is obviously for the first line, it's osimertinib is always a preference if cost is not an issue. But with exon 21 A58R mutation, dacometinib 2 is an option, but dose modification has to be taken care of, and the patients require a frequent visit. So most patients, what with dacometinib having seen is what we have seen, we have to modify it at regular intervals, and you have to follow up the patients. The cost surely of dacometinib is less as compared to those of osimertinib. But still, if we take the overall survival, so osimertinib even in the first line have given the maximum benefit, dacometinib just behind it. So we have to give the patient all the choices, and depending on the patient status, we can plan.
So there is one question, Amit, for you from the audience, that adenocarcinoma lung on osimertinib. There is everywhere response on PET-CT except leptomeningeal mets. So further choice of treatment.
So if there's a response everywhere except for the leptomeningeal, so that's the CNS meds. In that case, one may initially plan to double the dose, and along with that, an IT therapy can intrathecal therapy you can start in this patient.
Intrathecal methotrexate?
Yes.
Okay. Thank
Sure.
you.
Okay.
Thank you, Amit. Now for the next session, I invite Dr. Renu Mishra for a Roche-sponsored session, role of alectinib in first-line ALK-positive non-small cell lung cancer patients. Dr. Renu Mishra.
Good evening. First of all, I would like to thank the organizers and Dr. Tarachand sir for giving me this opportunity. I would please request to start my slides. Gitika. Oh. Will you be able to share my slides, Gitika? Thank you. Next, please. So I will be discussing on the role of alectinib in first-line ALK-positive non-small cell lung cancer patients. And my discussion would be in these heads: overview of non-small cell lung cancer, ALK testing, ALK-positive disease, what are the approved ALK inhibitors, and then Alecensa, that is alectinib. Next, please. So lung cancer is a significant global health issue. It is the second most common diagnosed cancer worldwide and leading cause of cancer-related death, with the 2.2 million new cases every year and 1.8 million deaths per year. Next slide. Adenocarcinoma is the most common form, and we all know lung cancer is a heterogeneous disease with non-small cell, small cell lung cancer, and the others included. And the non-small cell cancer itself has many subgroups like adenocarcinoma, squamous cell carcinoma, non-small cell, large cell, and others. Next. So lung cancer incidence and mortality in India. So there are 72,000 new cases detected every year and 66,000 deaths per year. Lung cancer is one of the most common cancer among men, being 51,000 new cases per year in males. Next. So in stage 4 lung cancer, we all know that molecular testing is important and recommended by various guidelines. And the molecular profile, nowadays we all do EGFR, ALK. These are basic mutations that we regularly, molecular test, which we regularly do in all stage 4 patients. Next slide, please. So ALK testing can be done by FISH, IHC, RT-PCR, and NGS. Next slide, please. So now we'll have a brief overview about the ALK disease. Incidence of ALK positive non-small cell lung cancer is relatively uniform among ethnicities. This is, although the incidence of EGFR mutation varies, as we all know, in Europe it is 9.5, in US it is 17, and it is highest among East Asian, that is 24.5%. But ALK positive NSCLC is around 3.5 in Europe, 3.4 in East Asia, and 8% in US. Next, please. So we average it out as around 5% of all patients of NSCLC are ALK positive. And more than, there is a clinical characteristics, like these patients are generally non-squamous histology. They are never smokers or former smokers, young patients, female patients, and who have EGFR or KRAS negative. However, these are not, characteristic. We have to do a ALK testing to be sure. Clinical features don't always predict the presence. Next slide, please. ALK positive non-small cell lung cancer is defined by the rearrangement of ALK gene within the chromosome. So this rearrangement causes a structural alteration, and so the expression of ALK fusion protein. Next slide, please. ALK mutation is reported in 3% of lung cancer, as we discussed. 3 to 8% is the range, and it is more common in adenocarcinomas and never or light smokers. Next slide, please. So the first molecule that was approved for ALK inhibition, that was crizotinib. So we can't continue our discussion without mentioning crizotinib. It was a breakthrough, a small molecule inhibitor of tyrosine kinase activity of MET, ALK, ROS1, and RON. And the crizotinib, it inhibits ALK receptor activation. Next slide, please. So this was a landmark study, Profile 1014, in the first line crizotinib versus chemotherapy. Next slide, please. So, and it was a huge success, we all know, and it introduced crizotinib as first line versus chemotherapy. But what is seen is that crizotinib is actively transported out of the blood-brain barrier. So the drug efflux transporter is expressed in several tissues, including liver, pancreas, kidney, colon, and at a very high level in brain. So crizotinib is transported back by the blood-brain barrier, and therefore it has a very low brain to plasma ratio. Next slide. So ultimately, the relapse in, if we start a patient on crizotinib, is more likely to relapse in brain, or after treatment, there is some response, and then there is brain mets. Generally, typically after 1 year or so, patient has a brain progression in the brain. Next slide. So next drug in the line was ceritinib, and Ascent, it compared it against chemotherapy. So crizotinib also had a, next slide please, had a similar issue, that it was effluxed by the transporters. So the CNS exposure of crizotinib and ceritinib is therefore inadequate to control the disease in brain, and CNS may form a sanctuary site for tumor growth. Next slide, please. So CNS is a common site for progression in patients treated with crizotinib and ceritinib, and it was seen that first site of progression, it was for 46% of patients treated with crizotinib and 42% when they were treated on ceritinib. Progression in CNS may occur due to development of either some resistance to ALK inhibitor, or alternatively, because of the inefficient penetration of these ALK inhibitors into the CNS. So this is a pharmacokinetic failure leading to disease progression. Next slide, please. Now coming to Alecensa, that is alectinib, we will discuss how it is different in its selectivity, potency, resistance mutation, and CNS penetration. So evidence based on alectinib in the first-line treatment of ALK-positive non-small cell. We all know the phase 2 study on the Japanese patients, then JLX, that is phase 3 study on Japanese patient, Alecia, that is for the Asian patients. So alectinib has the largest body of evidence with consistent results in phase 3 trials, supporting alectinib as preferred first-line treatment option for patients with previously untreated. So next slide, please. So coming to ALEX study, so it was a randomized trial comparing alectinib with crizotinib. So it was a 1:1 distribution. Alectinib is given at 600 mg BD dose, and the primary endpoint was PFS. Next slide, please. And the ALEX data cutoff and analysis were done at regular interval primary analysis in February, then first, second, and third exploratory analysis has been done. Next slide, please. So now looking at first the baseline characteristics of the patient that were receiving crizotinib and alectinib. So the median age was similar, male-female ratio is comparable, performance status is comparable, and we see all patients underwent tumor imaging at baseline, and ALEX is the first phase 3 trial to prospectively capture evolution of CNS disease through routine brain imaging, while it also included patients with brain mets. So next slide, please. Now updated ALEX, the final mature PFS assessment, we can see it has a proven protection from disease of nearly 3 years. That is 34.8 months. So the final PFS analysis of ALEX demonstrated that alectinib has the longest mature median PFS in the first line setting. It is providing 3 times longer efficacy benefit compared to crizotinib. Next slide. So in patients treated with alectinib, 43.7% of patients were event-free at 4 years, and was not established in crizotinib, which was not established in crizotinib treated patient. Next slide, please. Next slide, please. So the PFS subgroups analysis, we can see the forest plot. All the consistent with primary analysis, the hazard ratio for PFS was below 1 for all subgroups, with the exception of active smokers. All subgroups benefited with alectinib. Next slide, please. And the magnitude of PFS treatment effect was consistent across all the subgroups. It is indicating the benefit of alectinib over crizotinib. Next slide. So this was a updated the PFS by baseline CNS metastasis status. So if there were patients who had CNS metastasis at baseline, they also showed a benefit of 25.4 months, that is more than 2 years PFS. While without CNS met, it was 38.6 months PFS, more than 3 years. So protection lasts years, irrespective of CNS metastasis at baseline. Next slide, please. So the final PFS event-free rate, if we see, was higher with alectinib than with crizotinib, irrespective of absence or presence of CNS metastasis. Next slide. So the cumulative incidence of CNS progression, if we see, so we can see that alectinib actually reduces the risk of CNS progression events. It was a 84% reduction versus with crizotinib. So talking about the overall response rate, both alectinib and crizotinib have a high overall. However, DOR was longer with alectinib, suggesting a prolonged response, which appears to translate into significant PFS benefit. So best overall responses of alectinib is comparable. Next slide. And DOR, next slide, you can see the DOR is longer with alectinib than crizotinib. And treatment with alectinib significantly reduced the risk of CNS progression without in patients who did not receive prior systemic progression. Sorry. So here, patients with measurable or non-measurable baseline CNS mets, we can see 3 patients had CR, that is complete response, and 49 out of 64 had PR, while those with crizotinib, 0 patient had a CR. Next slide, please. Next slide. So if we consider the tumor reduction, so 43.7% of responder treated with alectinib demonstrated a more than 75% reduction. That is, alectinib had a deeper response than crizotinib. Next slide, please. So though the OS data is still immature and a follow-up analysis will be performed. Next slide. But updated ALEX is showing a trend to overall survival that lasts years. That is 6 out of 10 patients are alive at 5 years. So after a median follow-up of 48.2 months of alectinib, the OS data still remains immature, but the trend is favoring alectinib. Next slide, please. So now talking about the safety profile. So with a 3 times longer duration of treatment, the rates of dose reduction, interruptions, and discontinuation, they are similar with alectinib as well as crizotinib. So this demonstrates that alectinib is a generally well-tolerated drug, even over long-term use. The safety profile of alectinib continues to remain consistent and manageable. There are no significant safety signal observed after long-term use. The similar adverse events like nausea, vomiting, deranged liver functions, those are manageable, and those have been seen. No alarming signs have been seen so far. So coming to the clinical guidelines. So now NCCN prescribes alectinib as one of the first-line treatments in ALK rearrangement positive patients. And why do we prefer Alecensa over others? Because it has demonstrated a median PFS of nearly 3 years. In first-line setting, it protects and treats CNS mets, and it is the only ALK TKI that has demonstrated clinically meaningful benefit in OS versus crizotinib. That is a 5-year survival rate of 62.5% versus 45.5%. And of course, it is well tolerated with a manageable safety profile, which we have seen over long-term use. So efficacy conclusions, we can see that the updated ALEX confirms that alectinib shows superior in PFS and median PFS of 34.8 months. It has set a benchmark for the drugs. The longer DOR with alectinib, suggesting it provides a prolonged response, and it has a impressive CNS efficacy, both in terms of protecting and delaying the progression. And so it is NCC category 1 preferred. It is the standard of care in the first-line treatment of patient with ALK positive NSCLC. Thank you.
Thank you, Dr. Renu. So, what is your choice between alectinib and lorlatinib as a first-line ALK positive?
So, alectinib is of course a preferred option. Lorlatinib I would like to preserve for the next for the second, if in case of resistance.
After alectinib. So why do you prefer alectinib over lorlatinib?
Because the safety profile, the side effect profile of alectinib is more manageable than lorlatinib.
Okay, thank you, Dr. Renu. Now I invite Dr. Anu Rajpurohit, consultant medical oncologist, NIMS Medical College and Hospital, Jaipur, for the personalized therapy to improve further outcomes in BRAF-mutated metastatic NSCLC. Over
Thank
to
you,
you,
sir.
Anand.
Yeah, thank you, sir, for giving this chance. Thank you, organizers. Can I share my screen? Yeah, so my screen is visible.
Yes, ma'am.
Okay, good evening all. Today's my topic is to target BRAF mutation in patients of metastatic non-small cell lung cancer. So today we'll be dealing with understanding of the role of BRAF in metastatic non-small cell lung cancer, gaining awareness of BRAF testing methods and the diagnosis of BRAF positive NSCLC, and we'll review the data, the clinical data for the dabrafenib plus trametinib in advanced NSCLC. So coming to BRAF, this pathway we all know that it is KRAS BRAF MAP mediated pathway. By mutation in BRAF, it leads to activation of this pathway, leading to proliferation of the cells, leading to the cancer. So BRAF mutation is common in melanoma, colorectal, thyroid, followed by NSCLC, that is 2%. BRAF mutation occurs in 1 to 4% of all non-small cell lung carcinomas. BRAF mutation typically do not overlap with other common mutations, and BRAF mutation do not appear to correlate with age, sex, stage of diagnosis, or smoking status, unlike other common mutations. The most common type of BRAF mutation is V600E, and which occurs in 50 to 70% of the cases. Although V600 is the most common one, but in some cases we found a rare one also. So these are the other types of the BRAF mutation, but the treatment remains the same. BRAF positive has histological feature of suggestive of an aggressive tumor. If we see this graph, either we see disease-free survival or overall survival to chemotherapy, it remains lower compared to wild type of non-small cell lung carcinomas. Now coming to outcome in patient with BRAF mutation positive patient versus patient with wild type BRAF, we can clearly see the objective response rate is almost 50% in wild type, while it is only 30%, near 30% in BRAF positive patient. If we see the median PFS or median OS, it is clearly lower than wild type one. So we can see the treatment for the BRAF positive patient, it remains suboptimal because approximately 1/3 of the patient remains untreated because of the poor PS. And we have to, in the 60% cases, we have to do the BRAF supportive care. Doublet chemotherapy is the most common treatment, though it has lower response rate. In patient with driver mutation, targeted therapy can help in patient live longer. So this is the current guideline. If patient present in good PS, we usually give doublet chemotherapy plus minus targeted therapy depending on the age, PS, and the PD-L1 status, followed by maintenance. If PS is poor, either 3 or 4, we go for best supportive care. So this is a historical approach encourages serial testing with companion diagnostic. So if we have a patient of non-squamous NSCLC, we do a broad molecular profiling, including BRAF mutation. So both ESMO consensus as well as NCCN guidelines recommend to do BRAF mutation upfront when patient comes to us, so that we can know about the prognosis of the patient. Upfront BRAF testing is essential for patients with advanced NSCLC because BRAF does not appear to correlate with any clinical risk factors, unlike other common mutations, and it has more aggressive tumor biology compared to wild type 1. And by knowing the BRAF status, we can target this mutation. Now coming to the clinical data of Rafinib plus Mexel, that is dabrafenib plus trametinib. So what is dabrafenib? It is reversible, potent, selective inhibitor of RAF kinase, including BRAF 600, and particularly BRAF V600E and V600K. And trametinib, it is reversible, highly selective inhibitor of MEK1 and MEK2 kinase activity. So this is approved by DCGI. Dabrafenib in combination with trametinib is indicated for the treatment of adult patients with advanced non-small cell lung cancer with a BRAF V600 mutation positive patients. So rationale of combination of dabrafenib plus trametinib that we all know that by targeting both, we can improve the resistance. And by delaying the resistance, we can have a further better PFS and OS benefit. So this is phase 2 study of dabrafenib plus Naxel in BRAF positive patients. So they took patients with stage 4 BRAF positive NSCLC, ECOG PS 0 to 2, no prior treatment with either BRAF or MEK inhibitors, patients with symptomatic, non-stable, or more than 1 centimeter metastasis, brain metastasis were excluded. So they divided into 3 cohorts, cohort A, B, and C. In cohort A, they kept the patient who received more than 1 platinum-based chemotherapy, they give dabrafenib monotherapy, 150 milligram BD. In cohort B, they combined it with trametinib. And in third cohort C, in these patients, they did not receive any prior treatment. The patients were naive. So in upfront setting, they tried dabrafenib plus trametinib combination. So primary endpoint was objective response rate. All responses had to be confirmed based on RECIST, version 1.1. And the secondary endpoints were PFS, duration of response rate, OS, safety, and population pharmacokinetics. So dabrafenib and the trametinib combination in patient cohort A, if we see the median age was 66 and half of the patients were female, so male and female were equal. Almost 60% of the patients were white, followed by Asians and followed by Black people. And then if you see the ECOG, so most common ECOG was the PS1, but they also included PS2 patients. If we go by smoking history, 1/3 patients were never smokers, and 1/3 patient who had less than 30 pack years, and 1/3 were more than 30 pack years. So they included all the type of smoking history. And coming to the histology, the most common histology was adenocarcinoma. Prior systemic therapy, 1/3 patient received more than 3 lines of the platinum-based chemotherapy. So this is cohort B. Again, the median age is around 65. Male to female ratio is 50-50. Again, the whites were more, followed by Black and Asians. ECOG was also 0 to 1 and 2. Mostly were 0 to 2, 0 to 1. The most common histology was adenocarcinoma. If we go by the smoking history, the most common were the former smokers. And 1/3 patient received more than 2 lines of chemotherapy. So this is cohort C. Again, the age is same, the 67, male, female were. In this, the male were lesser than the female. Most common race was white, followed by Black and Asians. ECOG again 0 to 2. Most common histology was adenocarcinoma, but they also included adenosquamous carcinoma also. And by smoking history, the 1/3 patient had never history of smoking, followed by current and the former one. Nearly all patients had adenocarcinoma histology. Now coming to phase 2 study of Refinlab plus Naxel, they included 169 patients with stage 4 BRAF patients. The primary endpoint was investigator assessed objective response rate. So the dosing where the dabrafenib was given in 150 milligram BD dose. If you combined it with the trametinib, the dose is 2 milligram OD, and in treatment naive patients also the doses are the same. Now coming to the results, if we see in cohort A, the objective response rate is almost 30%, like 1/3 patient responded to treatment. If we see the duration of the response, it is around 10 months. If we see the median PFS, it is 5, and OS is around a year. Coming to the cohort B, in which they combined it with the trametinib, clearly the response rate is better. That is around 60%. The median duration of response is 9 months. In this cohort, patient also underwent complete remission. This waterfall chart shows that almost all patients somehow showed the response to this combination therapy. The duration of response is 9 months. And 50% of the responses were ongoing at the time of data cutoff. PFS with combination therapy was almost double what has been reported with dabrafenib monotherapy. So it is wise to use the doublet combination. So it is 9.7 months. And in independent assessment, it is 8.6 months. If we see the 6-month PFS, it is 65%. Now coming to the cohort C, in which the patient never received chemotherapy and they were chemo naive. So the duration of response is again 10 months, 10 to 15 months, and the over objective response rate is again 65%. And patient also underwent complete remissions. In this waterfall chart, we can see almost all patients showed some
Please try
response.
to finish in time, please.
Yeah, showed some response. The number of patients with confirmed overall response was 10.4 months. Now coming to the median PFS, this is 10.9 months. So these are the combined data of all the 3 cohorts. Clearly, we can see the benefit is more with combination therapy. Now coming to the adverse events. So pyrexia being the most common in all the patients, either in form of grade 1, 2, or grade 3 to 4, followed by asthenia, hyperkeratosis, decreased appetite, cough, fatigue, and skin reactions. So these are almost all patients responded to, almost all patients showed adverse event towards the therapy, almost 98%, but the grade 3 for only in 50%. So pyrexia was the most common adverse event, almost 46% of the patient. However, only 2% had grade 3 pyrexia. So how do we manage the pyrexia? So interrupt the treatment with the dabrafenib, that is dabrafenib, if the patient temperature goes about 38.5, and continue with the trametinib. Initiate antipyretics such as ibuprofen or acetaminophen or paracetamol, followed by consider oral corticosteroid if patient is not responding to above given treatment. So these are the guidelines how we manage the side effects. So first event, we try to hold the dose, we reduce by 1 level, we try to manage it with the NSAIDs. If not respond, then we give oral corticosteroids. So these are the levels of the drug reduction. And dabrafenib, it is 150 followed by 100, 75, and 50 is the last. While it is in trametinib, it is 2 milligram followed by 1.5 and followed by 1 only. So the safety profile of this combination is quite manageable and similar to the previously reported in melanoma studies. The most common adverse events were pyrexia, GI-related toxicities, and skin reactions. Thank you.
Thank you, Anu. Now, for the next session, I invite Dr. Deepak Shukla. He is a consultant medical oncologist at Manipal Hospital, Jaipur. He will be speaking on Pfizer-sponsored session, Walk the Frontline in HIV-positive non-small cell lung cancer. Deepak boss, please over to you.
Thank you, Dr. Tara, for giving this opportunity. Just a moment, I'll share my slide. Are my slides visible?
Yes, boss.
Okay.
Can you please make it
Yeah.
full screen? Yeah.
It's okay. Yeah. So I'll be speaking on the topic walk in the first line management of ALK positive non-small cell lung cancer. So we know that lung cancer incidence is increasing. So what the data shows that in the next 2 decades, the incidence will increase from around of lung cancer will increase by close to 20 to 40%. And we know that lung cancer is a lethal cancer. So the proportional increase in incidence will, in spite of all the efforts we are doing, will also lead to increase in the mortality in the coming years. So one of the success stories in the treatment of advanced non-small cell lung cancer are the patients who are ALK rearranged. So these patients constitute close to 3 to 5% of all the advanced non-small cell lung cancer patients. These patients tend to be of younger age. They are never or light smokers, and they usually have an adenocarcinoma histology. And to date, we have 5 different ALK TKIs approved based on the FDA since the last decade. So across the generation of these ALK TKI, the potency against the ALK inhibition increases. Also, the activity against the various ALK mutation increases, and also their CNS penetration increase. So what we know from the data from the first and second generation LTKI is that in comparison to chemotherapy, crizotinib showed a median PFS of close to 11 months. In comparison to chemotherapy, ceritinib showed a doubling of PFS, which was close to 16 months, while the brigatinib also showed a doubling of PFS, which was close to 24 months in the ELTA-1 trial. And till date, the best reported PFS was for the alectinib in the ALEX trial, which showed that the PFS was close to 3 years in this trial as compared to crizotinib. So the updated OS data from the Profile 1014 trial shows that in the chemotherapy arm, the median PFS was close to 48 months. And in spite this long-term follow-up of close to 4 years, the median has reached in the crizotinib arm. If we look into the OS data for ASCENT-4, in the chemotherapy arm, the median survival was close to 26 months, while in the ceritinib arm, it has not reached. And also, as previously discussed, that even in the ALEX trial, there is clear trend to favoring alectinib when compared to crizotinib, but still the data is immature. But there is a clear trend that using alectinib in the front line improves overall survival as compared to crizotinib. But there are certain challenges in spite of seeing this good data, because as discussed, these patients with ALK positive advanced non-small cell lung cancer are young. So they have a good, decent life ahead of them, which is hampered because with the available treatment options, the ALK resistance mutation is an issue. Also, even with the availability of best drugs, the control of CNS metastasis is an issue. Also, prevention of brain metastasis is very important, because we know that once a patient develops brain metastasis, the decline could be very rapid. So there is need for additional LTKI that prevent emergence of these resistant clones. So for this, lorlatinib was designed keeping these factors in mind, and it was designed to effectively prevent CNS metastasis and prevent progression in CNS metastasis, and also in order to bind with high affinity to most ALK resistance mutation that was seen prior LTKI. So CROWN trial was a phase 3 trial which enrolled advanced ALK positive non-small cell lung cancer patients, and these patients were included even if they had asymptomatic or treated or untreated CNS metastasis. And these patients were randomized 1:1 to lorlatinib 100 milligram once daily, and or to 250 milligram twice daily to crizotinib, and close to 150 patients in each arm were randomized. And the primary endpoint of this trial was PFS blinded independent committee review. So the baseline characteristics were well matched. What is important to note that nearly 25% patients in both the arms were having baseline brain metastasis at that time, and majority of them did not have received previous radiotherapy. So previously we had data for till 18 months follow-up, and recently the 36 months follow-up data for lorlatinib from this CROWN trial was reported. So what this trial at this extended follow-up showed that in the ITT population, the PFS was still not reached in the lorlatinib arm, while it was close to 9.3 months in crizotinib arm with a hazard ratio of 0.27. Also, what is encouraging to note that the overall response rate was nearly 20 percentage point better with lorlatinib. It was 78%, while it was close to 58% with crizotinib. Also, the median duration of response was not reached. If we look into the graph, the Kaplan-Meier curve at 36 months, nearly 63.5% patients were progression-free in the lorlatinib arm, as compared to 19% patients in the crizotinib arm. And the benefit was seen across the various subgroups favoring lorlatinib. If we look into the PFS in patients with or without brain metastasis, so patients with brain metastasis receiving lorlatinib, still the median PFS was not reached. But in crizotinib arm, the PFS was low, 7.2. Hazard ratio was 0.21 favoring lorlatinib. In patients who did not have brain metastasis with crizotinib, the PFS was slightly numerically better. It was 11 months as compared to crizotinib with brain mets. But if we look at its comparison with lorlatinib, again the hazard ratio was 0.29 favoring lorlatinib, and the median PFS was not reached. If we look into the time to intracranial progression with crizotinib, it was close to 16.6 months, while in the lorlatinib arm, it was not reached. Hazard ratio was 0.08. And the intracranial time to progression in patients with baseline brain metastasis was not reached in patients with lorlatinib, while it was 7.3 months in patients with crizotinib with hazard ratio of 0.1. And what is actually very encouraging to note that in patients who did not have baseline brain metastasis, only 1 out of 112 patients without baseline brain metastasis had an intracranial progression on lorlatinib. And if we look into the crizotinib, the 25 events were there in the crizotinib arm. And if we look into the hazard ratio, it is close to 0.02. So looking into the summary of the overall response rate, as discussed, it was 77% with lorlatinib. For crizotinib, it was 58%. If we look into the complete intracranial response rate in patients with measurable brain metastasis, it was close to 73% with lorlatinib, while it was only 7.7% with crizotinib. And if we look into the comparison at the extended follow-up of 36 months in terms of permanent treatment discontinuation, so in crizotinib arm, the discontinuation rate was close to 10%. And even at such 3 years follow-up, lorlatinib discontinuation rates were low, close to 7.4%. The safety profile for lorlatinib was similar to what was reported in previous interim analysis. The more treatment-related adverse events in lorlatinib were seen in terms of edema, hypercholesterolemia, hypertriglyceridemia, and also peripheral neuropathy and cognitive effects. While for crizotinib, it was more of diarrhea, nausea, transaminitis, vision disorder, and vomiting. And what this updated result showed that at 18 months, there was 7% discontinuation of lorlatinib. And at extended follow-up, this extended only to 7.4%. So for lorlatinib is efficacious and it is safe at 36 months of follow-up. And based on this data, now we have number of options for patients who are diagnosed with ALK-positive advanced non-small cell lung cancer. And in addition to other options, lorlatinib is also one of the options. But we do not have a head-to-head comparison between these trials. So to look into which of these LTKI could be a better option for our patient, a network meta-analysis was done, which included trials with these various agents. And what this meta-analysis showed that lorlatinib is an effective first-line treatment for ALK-positive non-small cell lung cancer when compared to crizotinib or any other next-generation LTKI. But in terms of overall survival, there was no statistical difference between lorlatinib as compared to other LTKI. But it is important to note that in majority of these studies, as also previously discussed, the OS is still immature and has not reached its median in a good number of these of these trials enrolled in this meta-analysis. So the conclusion in this meta-analysis was that in terms of PFS, lorlatinib was the best drug, but future head-to-head trials are needed to assess relative efficacy in comparison to other drugs like with lorlatinib, alectinib, and brigatinib. And again, this is the same in this meta-analysis. There, the PFS advantage with lorlatinib as compared to brigatinib and alectinib, the probability to reach best PFS was 98% in favor of lorlatinib. And also this data again shows that the best PFS advantage, or the best probability to achieve the maximum PFS is with lorlatinib as compared to alectinib or brigatinib. And if we look into the PFS benefit, whether patients had CNS metastasis or patients are without CNS metastasis, so in this paper there was a ranking in terms of ranking, lorlatinib fared the best, followed by alectinib, brigatinib, and crizotinib in patients whether they had CNS metastasis or not. So this meta-analysis concluded that in terms of PFS, lorlatinib is better as compared to brigatinib or alectinib, and there is no significant difference in terms of overall survival and adverse effect analysis. So the journey for patients with advanced KAL-positive non-small cell lung cancer treatment has evolved from the initial trial of crizotinib, where a PFS of close to 11 months was reported, to close to 36 months with alectinib. And now with the CROWN data, where 63%, close to 63% patient being progression free at 36 months, the journey goes on. And possibly the CROWN data, though the median PFS has not reached, will most likely surpass the median PFS for alectinib. So to conclude this talk, the PFS at the extended 18 months of additional follow-up showed that at 3 years, 63% patients with lorlatinib were progression free as compared to 19% with crizotinib. What is equally effective or encouraging to note that is the efficacy of lorlatinib to prevent brain progression. So only 1 out of 112 patients without baseline brain metastasis went on to develop brain metastasis, and there were no new safety signals observed. And with this data, the efficacy of lorlatinib over crizotinib is confirmed, and the drug is active for patients with newly diagnosed KAL-positive non-small cell lung cancer with or without brain metastasis. Thank you.
Thank you, Deepak Bose.
Thank you.
So again, the same question for you, Deepak Bose. As Dr. Renu said, what is your preference now, alectinib versus lorlatinib?
So, Dr. Tara, I actually don't see a lot of ALK-positive patients. Means I think you will be the best person to answer which will be the best drug. But looking at the data, I think lorlatinib is means definitely closing the gap. Previously, we have the issue that the follow-up is low. We don't know how the CNS toxicity and other issues will pan out. But with the extended follow-up, with the discontinuation rate of less than 8%, in the alectinib data which was discussed previously, there was discontinuation rate of 14%. And the intracranial progression-free survival, I think the best drug should be lorlatinib. I am not a fan of sequencing. Actually, we don't know in India how patients will be followed up. So possibly the first drug should be the best in my mind. So lorlatinib.
And what about those lipid profile and the pedal edema which we see with the lorlatinib?
Yeah, I think
the diarrhea in alectinib.
Yeah, actually, we have to manage that by dose reduction, dose interruption. So again, that's what is encouraging. So at 36 months of follow-up, even with these side effects, in a phase 3 trial, if only 7% or 8% patients are discontinuing, I think dose reduction, use of diuretic, I think this should be the way forward. It is a once daily dosing again. So I think this can be managed.
Okay. Okay, boss. And I would request you to be there in the panel, so it will be
Okay.
interesting if you are there in next panel. I
Okay.
invite Dr. Rajit Chanana for the moderation of the next panel discussion on the management of ALK positive non-small cell lung cancer. He is a consultant medical oncologist, Dharamshila Narayana Super Specialty Hospital, Delhi. Over to Rajit.
Good evening, everyone. Thank you, Dr. Tarachand. So, can the
And-
organizers please allow me to share my slides? Yeah.
Your panelists are, I invite your panelists are also there. Dr. Ankit Agrawal, he is a consultant medical oncologist, Gitanjali Hospital, Udaipur. Dr. Ankur Punia, he is associate professor, Department of Medical Oncology, Shri Ram Cancer Center, Mahatma Gandhi Medical College, Jaipur. Dr. Anu Raj Purohit, she is a consultant medical oncologist, NIMS Medical College and Hospital, Jaipur. And Dr. B.S. Ankit Nehra, he is a consultant medical oncologist at HCG Hospital, Jaipur.
So, yeah. Hi, good evening, everyone. Thank you for joining. I think we have had too much discussion on ALK, so this will be just a repetition of what we have discussed. So, I would also request Dr. Tarachand to be the part of the panelist. Can add some spice to it. So, maybe I'll start the first question to Dr. Ankit Agarwal. So, what is the incidence of ALK mutated non-small cell lung cancer in your practice?
So very rare, less than 2%. We don't usually see. I don't see a lot of ALK positive patients in my practice.
Okay, so what patients do you see? Which they are EGFR mutated or they are
EGFR
driver mutation?
So EGFR mutation incidence in my practice, if I take general patients of lung cancer, is around 10% in my clinical practice.
Okay. So Dr. B.S. Ankit and Dr. Anu and Dr. Ankur, so what is your the percentage of ALK positivity?
So it is only around 1% in my clinical practice.
Okay.
Yeah, good evening, sir. This is same 1 to 2% hardly.
Yeah, I have also seen only 3 patients in last 4 years.
I've seen only one.
Okay, so my practice, I usually see smokers, so I don't get a lot of mutation, but out of the mutation that I get, I don't know how, but ALK is the most common. So my next question to Dr. Anu, so what is the preferred testing platform at your center? So what is the preferred choice and what is the practical test that you do?
So practically for ALK, sir, I'm doing IHC.
Okay.
But if I'm sending NGS for the panel, like for the multiple genes, then it is included in that. So I don't.
So
do
are
it
you
separately.
comfortable starting treatment based on the IHC report?
Yeah, if it is strongly positive 3+, then yeah.
So yes, IHC is one of the standard testing platform for ALK. So I think all of us are comfortable, and if possible, NGS can give us a better idea. So Dr. Deepak, so you presented this study. So what are your impressions from the data of the CROWN trial? So I think Dr. Tarachand has asked few questions. So, but maybe you can just give a gist of.
Yes, so sir, the data looks good actually. With previously at 18 months, we had very short follow-up, but at this 36 months follow-up with the median PFS that is not reached, approximately at 36 months, 63% patients being progression-free, and the discontinuation rate being means less than 10%, I think, and once daily dosing of lorlatinib, I think the data looks good.
Yes, definitely the data looks good. So Dr. B.S. Ankit, so how likely this data is likely to impact your choice in the first line setting, and whether presence or absence of brain mets would change your treatment management?
So with the CROWN study and CROWN data, sir, the PFS is 36-month PFS is almost around 70%. So yeah, definitely I would consider lorlatinib as a first line option, or a second generation alectinib or brigatinib. And no, the presence of brain mets won't change my decision, because all of these 3 drugs are crossing the blood-brain barriers.
Yes, correct. So I don't think there is actually a choice except the toxicity profile between the 2 drugs as of now. So Dr. Tarachand, would you like to comment why and what would be your first choice of treatment? So my point is that alectinib, there are patient has to take it twice a day with 4 tablets. So that may be a compliance issue, but in terms of toxicity profile, I am very comfortable with alectinib. So, I am confused. So maybe you can share some input.
Rajit, actually, what is my take? Actually, whenever I see a new drug and if it is impressive in a data, usually I start using how it goes actually. So whenever I saw in my practice the ALK positive, first thing, initially at that I use the serotonin, but next patient I use lorlatinib only whenever the data came. And yes, I am using comfortably. Initially, there was some derangement in the lipid profile, and it was around grade 1 pedal edema only. But when I added the rosuvastatin 10 milligram daily, and the profile become normal, and now the patients are taking happily without any complication. And yes, they are responding very well, and within 15 days, usually becomes patient 90% symptom free. And I have no experience with alectinib.
You have no experience with
alectinib.
So what would be your second line of treatment post lorlatinib? So have you reached that stage yet?
Not yet. Only 2 patients are there, and they are going around 1 year now.
Okay. So Dr. Ankit, so if you start with lorlatinib, so do you have that concern that what treatment would be the second line once you have given lorlatinib?
Yes, I think that will be a big concern. Lorlatinib, we don't have a very strong data to know what exactly is the second line management. So yes, obviously, second line will be an issue, will be of concern. But personally, if I have to treat my ALK positive patient, I think lorlatinib should be a good option.
So would you, give alectinib, or will you give chemotherapy to patient who has progressed on lorlatinib?
So a patient who has progressed on lorlatinib, considering the CROWN trial data now, already it has given a good amount of PFS. If I was to give treatment, second line, I'll prefer chemotherapy.
Correct. So I think we'll discuss these points in coming slide also. So Dr. Anu, so would you prefer to do an MRI brain in stage 4, especially if the patient is mutation positive, whether the patient has symptoms or not?
Yes, so even if the patient is asymptomatic, I would like to do it, because if in future patient develops either symptomatic brain mets or asymptomatic, we can compare it. Yeah, I want to do it.
Okay. So any other difference of opinion regarding MRI brain in the upfront setting? So I think all of us agree that MRI brain should be done in first line setting, even if the patient is not symptomatic. So I think the main goal is just to document it. So I think the treatment can be started, but over a period of time, we can get the MRI done. We should not push for it, because patient has already done so much test. I think, at least I feel that many of my patients, they are already frustrated ki doctor saab treatment to start karo. So it is important.
Just a point, sorry to disturb. So if a patient has undergone a PET and not showing any brain metastasis, no symptoms, I think I won't push for doing an MRI brain.
Correct. So you would push for treatment, of course, and then maybe, if possible, then a baseline MRI. So the reason is explained in this slide that CNS, it's a common site of progression, and it in 46% of patients treated with crizotinib and 42% of patients treated with ceritinib, they have CNS mets at the time of progression. So it is due to one or more known mechanism of resistance, and alternatively, CNS progression may be due to insufficient penetration of the ALK inhibitor, especially first and second line. So the CROWN trial that was discussed by Dr. Deepak, so I'll not repeat it. So it has shown a very good data. It had patients with or without brain mets, so it has shown intracranial activity also, and the PFS is remarkable as compared to crizotinib. And the time to intracranial progression was also better. So I'll ask this question to Dr. B.S. Ankit. So what are the key factors that you consider apart from finances for deciding first line treatment of ALK positive patients?
So I'll be considering apart from finances, what comorbidities the patient is having. If the patient is already having a hypertension or a hypertriglyceridemia or a deranged lipid profile, I would select alectinib over lorlatinib. Or if the patient is already having symptomatic CNS mets, In that case also, I would like to go with that.
So my question is that basically if the patient does not have any CNS mets and is, will you be comfortable starting with crizotinib or ceritinib as first line treatment?
With crizotinib and ceritinib, eventually the switching the therapies in the total PFS was not that good if we compare it to either the alectinib, brigatinib or lorlatinib. So I would like to start with the second generation TKIs, preferably Elec or Brega, or third generation lorlatinib.
So correct. So first line should be one of the later generation of TKI. So efficacy should be best in the first line with maximum benefit, and it should be efficacy. It should have shown CNS efficacy with the safety profile. So NCCN shows that there are 5 TKIs that can be offered. So it is good that we can offer to our patients, those who cannot afford the higher third generation TKI, which are expensive. So again, I'll ask Dr. Deepak. So in terms of side effect profile, I think you have discussed, but have you personally experienced any significant adverse event with the lorlatinib?
So sir, I have not used lorlatinib.
Okay, so maybe anyone who has used it can share their experiences in terms of quality of life and adverse event management. Dr. Tara Chand, Dr. B.S. Ankit, Dr. Ankit, Dr. Anu.
I already mentioned that I'm using rosuvastatin from the baseline already.
So you start lorlatinib.
No, actually, I have only 2 patients. So in both patients, I had the experience of the deranged lipid profile, so I added rosuvastatin. And
so you have added it on baseline or at
at the time of lipid profile derangement.
Okay, so after that, it was controlled.
Yes, this was controlled.
Okay, and there was no other event related to hypercholesterolemia, and edema was also manageable.
Yes, fortunately, no.
So as discussed, I think the most important and common side effect is edema and hypercholesterolemia and diarrhea, which is mostly manageable. So these are the side effect profile of different approved TKI inhibitor in first line setting. So alectinib, I think, is the safest of all in terms of side effect profile. That's what I feel. And lorlatinib, I have just started one patient on this molecule, so my experience is also limited. But metabolic side effects should be monitored. So in terms of dose adjustment and management, as Dr. Tara Chand suggested, that we the patient may require lipid lowering agent. And the patient should be made aware that there should be regular monitoring of lipid. And based on this chart, we can introduce lipid lowering agent in case of moderate to severely high cholesterol. And it has certain unique side effects in terms of CNS effects like change in cognitive function, mood and speech, generally, which is mild in severity. So I'll skip this slide. So this is an interesting question. So Dr. Anu, so if the patient has progressed on first line, suppose ceritinib,
okay,
would you directly start the patient on alectinib, or you will start the patient on lorlatinib, or you will do start with chemotherapy plus crizotinib or ceritinib, or you will prefer to do a repeat biopsy? And if yes, what is the purpose of repeat biopsy, and where do you send the sample for ALK mutation analysis? Because I really don't know where do I send it.
Okay, so if there is progression of the first line, suppose ceritinib, then yes, we should do biopsy to look for the resistance mutation, because even if we are using alectinib, some of these mutations are resistant to alectinib also, though this problem is not with lorlatinib. So ideally, yes, we should get it done.
And what test do you do in the biopsy sample?
And yes, sir.
Okay, so do you think that the NGS that we get it done routinely for the lung panel will give you these mutations?
No.
So that is what is my question, that where do you send this for? Because I tried, I was not able to figure it out. That I know that probably lorlatinib works best in those patients who have G1202R mutation, which is the most common mutation. So, but where do I send it? So
So,
anyone,
just actually, I heard a talk from Dr. Ulas Batra recently. So they have started doing, I think, ELK mutation testing as a part of study, or so they are doing at RGCA, I think.
yeah, so it is mostly as a part of study only. Initially, I think MedGenome did it with Tata, and now Rajiv Gandhi is doing it. So, so what is the point of doing a biopsy if you don't know that what mutation we'll get? So that is what I was trying to ask. So will you still do a repeat biopsy if the patient has progressed, or you will directly start on a higher TKI or chemotherapy?
I think better to start on
Sometime-
lorlatinib. Sorry, please.
Yeah,
Yeah.
lorlatinib, yeah.
So lorlatinib or alectinib, and why? So not because this is a Pfizer sponsored session, because previously was a Roche sponsored session. So alectinib or lorlatinib?
So because maximum mutation resistant mutation are sensitive to lorlatinib, so yes, lorlatinib, sir.
And have you ever given to a patient who has progressed on ceritinib to?
So not in practice, but yes, when I was in residency, yes, that time we used to give.
Okay. So Tarachand, what would be your preferred choice if the patient has progressed on crizotinib or ceritinib? Whether you will start on alectinib or the newer molecule, whoever comes to you and promote their newer molecule, you will start that.
No, not the promotion, but yes, the data. Actually, not Rajesh, you have taken my point mistakenly. That is because of the data only also. But I would agree with Anu that because the lorlatinib has a sensitivity across even the resistant mutations maximum. So I will go with the lorlatinib in second line.
Okay, so
Because I don't have the
so
test
anyone will be comfortable using alectinib, because I think the data is more with alectinib. The data is more with alectinib, but the resistant profile, what the in vivo study is showing that probably lorlatinib would be better in terms of in this resistant mutation, but the data I think is more with alectinib. So anyone would start alectinib.
So just sir, there is an option, even if a patient progresses on alectinib, we have an option of offering lorlatinib.
Yes.
So in I think in that case, possibly I may go for sequencing.
So in your talk, you told that you are not in favor of sequencing because you want the best treatment to be
sir,
given.
I also mentioned I don't see these patients often, but if at all, for whatever reason, I've started with crizotinib, most of these resistant mutations are sensitive for alectinib. So if we start with crizotinib and then move to lorlatinib, I think subsequently offering alectinib won't be a very good option. But there is data for lorlatinib after progression on alectinib.
Yes, so that may be a reasonable approach. We have one more TKI to be offered if we give alectinib. So, but I don't know which one is the correct option. But both are correct. So both alectinib, lorlatinib, they are shown to be active in the resistant mutation that the patient develops after first or after crizotinib or ceritinib. So ALK G1202R, which is the most common, I think, resistant mutation to the first and the second generation TKI, and lorlatinib offer the broad spectrum activity against the almost known ALK mutation profile. So this is the mutation that develops after each of the molecule. So G1202R is the most common mutation that develops. So apart from this, I think MET is an important resistant mechanism that may be identified in the biopsy sample that we do after progression. So apart from that, I don't think that biopsy after first line progression of ALK inhibitor would actually help unless we are doing some research or as a part of clinical trial as of now. So this is a slide showing that the PFS of lorlatinib as per the lines of therapy. So it is trying to show that if it is given as a prior line of therapy, it shows a better PFS as compared to second or third line. So sequencing of ALK TKI, there is one theory that if we give first crizotinib, then alectinib, then lorlatinib, then obviously it leads to more ALK resistant mutation. So as more generations of ALK TKI, they are sequenced, so more difficult ALK resistant mutation can appear, which becomes difficult to treat. So there are two different approaches. So which would you prefer and why? So maybe Dr. Ankit can take it. So it is called as either interventional approach or preventive approach. So basically, preventive approach means that to start with a potent and longer response TKI, and interventional approach means that sequencing. We start with crizotinib, and then based on resistance mechanism, we start on the second or third generation TKI.
I will choose preventive approach over the interventional approach because of the already the reasons are discussed.
Yes, so I think that is the most practical thing that we usually follow. So this slide has been shared 2 or 3 times in the previous presentations. So I think the best options that we have is the last two. Either we give alectinib followed by lorlatinib, or we give lorlatinib as first line. But there is definitely a problem in the second line setting. But I think as the data becomes more mature, we'll probably get a better second line option. So it's very difficult to choose between the 2 lines of treatment. So maybe lorlatinib is slightly better in terms of CNS profile, but I don't have any hard point to decide between the two. So the key takeaways are that in treatment naive ALK positive non-small cell lung cancer compared to crizotinib in first line, lorlatinib resulted in a significantly longer PFS, higher overall and intracranial response rate, and improved quality of life. The safety profile is manageable. Grade 3-4 adverse events, they were more as compared to crizotinib, but they were manageable. And with sequential ALK inhibitor treatment, approximately 35% patients developed ALK resistance mutations. On lorlatinib with a solvent front, and ALK G1202R containing compound mutations, which may become the most common on-target resistance mechanism and are predominantly refractory to all known ALK inhibitors. So these results support the use of lorlatinib as an effective first-line treatment. So I think this is because this is a Pfizer sponsored. So this is the key takeaways from this presentation. Thank you, Dr. Tarachand. Thank you, all my panelists.
So I want to raise a point here. So if we see the first line, lorlatinib used the CROWN trial, there was difference between Asians versus non-Asians. So how do we take it?
Difference between
Asians and non-Asians. So how to interpret that data?
So Indians are,
not Asians, yeah.
They are Asians. If you want to support the drug, you can call Indians as Asians. So it's up to you basically. So unless we have the Indian data, obviously it's very difficult to interpret this result, because Japanese patients somehow they have different pharmacogenomics and as compared to the Indian population. So I think this is what I can say. Maybe if someone else can add to this question. Dr. Tarachand, if you can add between Asians and non-Asians and how to interpret this data for our Indian profile.
It's up to the choice which drug I am using at that time. So,
I think it's very difficult to interpret that data. It's predominantly Japanese, and as Dr. Rajesh has said, Japanese patients, they have a entirely different profile. They do probably do very well in all the trials. Okay, I just wanted to have a 2-minute discussion. I have a young guy who's ALK mutated stage 4 lung cancer. He was started on alectinib somewhere. Then he presented to me after 1.5 years of alectinib, progressed on alectinib, systemic progression. That time he had no money, so we could manage brigatinib. We imported brigatinib through the it was provided free to him. He has been on brigatinib now. After 6 months, he has progressed on brigatinib. That time he was not willing to go for chemotherapy or anything, so there was no choice, and we could only give him brigatinib that time. So 1.5 years of alectinib, then brigatinib. We could not go for any mutation testing, anything. And now he has progressed on brigatinib after 6 months. 6 months PFS of brigatinib, initially 1.5 years of PFS of alectinib. GC is still good. Performance status is 2. He is a candidate for chemotherapy.
So,
Now-
if the patient is getting brigatinib as a part of compassionate program, I would be tempted to give combination of chemo plus brigatinib.
Okay. Now, that time he was not willing for chemotherapy, so we were able to use only brigatinib. We didn't give him chemotherapy that time, and now he has progressed on brigatinib. There are systemic progression has appeared now, and it's been 6 months now. So 6 months PFS on brigatinib.
So one more option could be there, that you can give chemotherapy for now, and sometimes means possibly some of the clones possibly that are not responding maybe may respond to chemotherapy, and then subsequently you can try with crizotinib or any cheaper option in later line.
And also try to get a liquid biopsy for looking for other resistant mechanism like targetable resistant mechanism.
So anyone who's willing to use lorlatinib for this patient, in case if I request Pfizer people to provide him for a good amount of discount. So can I go ahead with lorlatinib?
Yeah, lorlatinib can be used.
I would not be comfortable after alectinib and brigatinib. Chemotherapy should be the preferred option. Maybe after chemotherapy, then you can give some TKI.
Right, that is the concern.
I also agree that if we are not finding any lorlatinib sensitive clones, then we should go for the chemotherapy, I think.
Exactly, because the concern is he might not be a good candidate for chemotherapy later on. His performance status might deteriorate as the disease progresses. So, right, I'll just counsel him for chemotherapy then.
Yeah, and because after TKI, usually patient deteriorate rapidly.
Right. Okay, Tara, thank you.
Thank you, Rajan. Thank you, Deepak Bose and Anu and Ankit.
Thank you, sir. Thank you.
So it's a wonderful discussion. Now we are moving towards the next BMS sponsored session. Dual checkpoint inhibitors in first line in metastatic NSCLC. Dr. Rohit Ravelo will be speaking on this. Assistant Professor, Medical Oncology, Ananta Institute of Medical Sciences, Raipur. Rohit, please.
Thank you, sir. Can I share my screen now? Are my slides visible?
Yes, sir. Now.
Are they visible now?
Yes, sir.
Okay. Good evening, everybody. I'm Dr. Rohit Ravelo. I'm an assistant professor in medical oncology in Ananta Institute, Udaipur. I'll be taking today's presentation on dual checkpoint inhibitors in first-line metastatic non-small cell lung cancer. So we'll be going through this presentation in the following headings: epidemiology and disease burden, the histology and staging in non-small cell lung cancer, the guideline recommendations, unmet need and rationale for first-line small cell lung cancer, and what is the mechanism of action of Opdivo and Yervoy, treatment of first-line metastatic small cell lung cancer with a focus on these two clinical trials, the CheckMate 9 LA and the 227 Part 1. So going through the epidemiology and disease burden, lung cancer causes most cancer-related deaths worldwide. As per Globocan in 2020, in the US, about 228,000 patients of lung cancer are diagnosed each year, and 135,000 people die. And as per the European Union data, about 410,000 patients are diagnosed, and about 275,000 predictably die, as per data from 2017. So as this slide shows, that it's definitely a leading cause of mortality worldwide. Looking at India, there are about 72,000 new cases diagnosed every year, and 66,000 people actually die out of lung cancer each year. So the incidence is about 5.5 per lakh population, and the prevalence, the 5-year prevalence, is about 72,510. The source being Globocan 2020. So
Sir, your voice is not audible. Rohit sir, your voice is not audible. Rohit sir, are you there?
Network is weak.
Yeah, I already informed him.
Okay, am I audible right now?
Yes, sir, your voice is audible now.
Okay, so slides visible?
Yes, sir.
Okay. So yeah. So now, what is the synergism between the action of an anti-PD1 and an anti-CTLA, which has been demonstrated by Opdita with the Yervoy combination? So one can see that the anti-CTLA4 component, that is Yervoy, it induces de novo anti-tumor T cell responses. It enables adaptation to evolving tumor and promotes emergence of memory T cells. It also causes a compensatory increase in the tumor PD-L1. And Opdita, which is an anti-PD-1 molecule, restores anti-tumor T cell function, enhances pre-existing T cell responses, and increases cytokine production. So combination between a CTLA4 as well as a PD-1 should actually give a more synergistic mechanism of action. That is the reason why these two drugs have been combined to help target the tumor cells better. So data suggests that certain combinations may overcome the limitations of monotherapy. CTLA4 blockade results in distribution of activated T cells to tumor site. And in the tumor microenvironment, PD-1 blockade results in targeted cell killing and inhibition of the AKT protein kinase B activation by preventing the PIK3C activation. So because of this, these two drugs have been combined in these two clinical trials, the CheckMate 9LA and the CheckMate 227 Part 1A. So let's discuss the 9LA trial first, where first-line Opdivo plus Yervoy was combined with 2 cycles of chemotherapy versus 4 cycles of chemotherapy alone in patients with metastatic non-small cell lung cancer. The eligibility criteria was stage 4 or recurrent non-small cell lung cancer with no prior systemic therapy and no known sensitizing mutations, with an ECOG performance status of 0 to 1. So no, PS2 was not taken in this particular study. They were stratified by PD-L1 status as less than 1 and more than 1%, and squamous or non-squamous histology. The combination was 3-weekly Opdivo with chemo for 2 cycles of chemo, and Yervoy was given at 1 milligram per kg once every 6 weeks. And chemo was given for 4 cycles, and there was an option of maintenance pemetrexed in the non-squamous variant. So immunotherapy was continued for up to 2 years maximum, or until disease progression or unacceptable toxicity. And they also looked at certain other mutations, where the percentage of KRAS in this particular trial was found to be 39%, TP53 was found to be 60, STK11 was found to be 27, and KEAP1 was found to be 10%. So these are the baseline characteristics are well balanced across all treatment groups, as can be seen in the figure. So what we look at the 3-year OS advantage, if you look at it, is 27% OS benefit with the combination of Opdivo with Yervoy plus chemo versus 19% only in the chemo alone. And in patients with PD-L1 less than 1%, there was a 25% OS benefit with Opdivo and Yervoy versus about 15% in the chemo alone. The median OS was 17.7 months versus 9.8 months. This is in the PD-L1 less than 1% population. And when PD-L1 was more than 1%, the median OS was 15.8 versus 10.9 months. So there was a 28% OS benefit versus 19% at 3 years. So OS advantage when compared between PD-L1 1 to 49 versus PD-L1 more than 50, it shows that results were consistent amongst both groups, showing improved benefit with the combination of the Opdivo with Yervoy plus chemo over the chemo alone. The PFS benefits were well maintained at even 3 years of follow-up, and duration of response benefits were also well maintained, as seen above. Obviously, patients who had, patients who had ongoing responses. A little bit of confusion is there, because here actually ongoing responses at 3 years were slightly more with the PD-L1 less than 1% population as compared to the PD-L1 more than 1% population. But by and large, the responses were seen in all randomized subgroups. And if you look at the KRAS mutant and the KRAS wild type patients, one can clearly see that at 36 months, the KRAS mutant variant had a median OS of 19.2 months versus 13.5 months, and in the wild type, immunotherapy did not help much because the hazard ratio is coming to 1, whereas in the mutant variant, the hazard ratio is 0.72. In the TP53 variant also, you can see in the mutant, the hazard ratio is 0.82, of course, crossing unity, and in the TP53 wild type, it is 0.96. So, and in the STK11 mutant, you see it is 0.79, and in STK wild type, it is 0.90. These were the side effects. So about 47% of the patients had grade 3-4 side effects in the immunotherapy arm. 16% had side effects resulting in discontinuation of any component of the regimen in the immunotherapy arm, whereas only 5% in the chemo arm. But chemo, as we remember, was only given for 4 cycles with maintenance only for the non-squamous variant with pemetrexed. So definitely there is a benefit of this first line, giving first line immunotherapy with the combination with 2 cycles of chemo. Definitely the side effect profile, if you look at grade 3-4, is just 4.5% skin toxicity, but overall about 40% would have some sort of grade 3, any grade toxicity in the skin. Endocrine toxicity was about 22%, and gastrointestinal toxicity was about 22%. Hepatic was about 12%. So these are the side effect profile of this particular combination that was seen. So the 3-year OS was 27% versus 19% in the combination versus the chemo arm. The PFS and duration of response benefits were maintained. In exploratory analysis in patients with non-squamous histology, a trend to OS benefits was observed with first-line Opdivo, Yervoy chemo versus chemo, regardless of the mutational status. No new safety signals were seen, and these updated results actually put this into the guidelines. So the next trial is the 5-year survival from CheckMate 227. This is Opdivo plus Yervoy versus chemotherapy as a first-line treatment in metastatic small cell lung cancer. So basically, in the part 1A, PD-L1 expression more than 1% was taken, no prior systemic therapy, stage 4 or recurrent, no sensitizing EGFR mutations, ECOG performance status 0 to 1 again, stratified as squamous and non-squamous. So they were randomized, 2-year max duration of interval therapy, treatment-free interval was taken, and subsequent systemic therapy also was considered to find the PFS2. So well randomized across all treatment groups. The 5-year OS was 25% in the Opdita plus Yervoy group in patients with PD-L1 more than 1%, as compared to about 14% in the chemo arm. So there was long-term durable overall survival benefit. The PFS was 5.1% in this versus 4.2% versus 5.6 months in the chemo arm. And but the primary endpoint obviously was overall survival, and that is where it actually did matter. So if you look at the duration of response, it was 24 months with the combination versus 15.7 months with the Opdita alone versus 6.7 months with chemotherapy. So efficacy outcomes were improved with the Opdita plus Yervoy versus chemo in 5-year survivors. Amongst 5-year survivors with a maximum of 2 years of immunotherapy, 66% remained disease-free more than 3 years after discontinuing therapy. By 5 years, the majority of survivors in the chemo group had received subsequent immunotherapy, as that would be obvious. The median duration of study treatment among 5-year survivors were for patients with PD-L1 more than 1%, 17.7 months, and in the combination versus and 6.2 months in the chemo arm. So this is in patients who about 15% of patients, 12 to 15% of patients actually moved beyond 3 years, and these patients tend to do extremely well. So in these particular patients, if you take that subset of patients who were alive beyond 3 years, right, their median PFS was 59.1 months. The 5-year PFS was 49%, overall response rate was 71%, and the 5-year duration of response was 54%. So as one can see, right, these patients who do well with the combination tend to have very sustained benefits. So in these patients who are 5-year survivors, right, you can look at the kind of subsequent therapy taken. So almost 66% of the patients did not take any other subsequent therapy. Subsequent immunotherapy was taken in 14% of the patients, and systemic therapy was taken in about 20% of the patients. But in the chemo arm, as one can see, like most of the patients, more than 74% of the patients received immunotherapy. So definitely there was some component of immunotherapy that helped them achieve that sort of survival. So the treatment-free interval, if you look at 36 months, was seen in about 66% of the patients with the Opdita plus Yervoy. So just going through the safety profile, as you can see, the grade 3-4 safety profiles was seen in about 35% of the patients, but the kind of side effects that you see will be different with chemo, will be different with the immunotherapy arm. Definitely the combination, if you compare it with just giving Opdita alone, it doubles. So 19.4% had complications, grade 3-4 serious adverse effects when only Opdita was used, and 32% had when the combination was used. So the immune-mediated side effects definitely lead to more, it will be more with the combination as compared to giving Opdita alone. But in this, what one thing they have noticed is in the 5-year analysis is the 5-year OS was 24 versus 14%. The duration of response was 24.5 months versus 6.7 months in the PD-L1 more than 1%, and 90.4 versus 4.8 months in the PD-L1 less than 1%. So this led to a significant increase in 5-year survivorship. That is, in those 15% of the patients who actually went beyond 3 years, in these 5-year survivors, it actually improved their 5-year survivorship. Responses were maintained for more than 5 years in more than 40% of those who had these initial responses. The majority remained treatment-free for more than or equal to 3 years after treatment discontinuation, and the quality of life was similar to the US population, which is a very important point when it comes to metastatic cancers. So even the guideline recommendations now do recommend Nivo-AP with chemo or Nivo-AP alone when PD-L1 is more than 50% in both the squamous and non-squamous populations. And in patients who have 1 to 49% also, Nivo-AP has been approved in both squamous as well as non-squamous. So this is a non-chemotherapy based regimen. It has category 1 recommendation even in the 1 to 49 age group. So this is the big change that has happened. So definitely this is a protocol that one can keep in mind when treating these patients of non-small cell lung cancer. So that, I'm sorry, I just crossed my time limit. I hope I was audible.
Yes, sir.
Okay, thank you. I hand it over to the moderators.
Thank you, Rohit. For next session, I invite Dr. Nandini Menon. She will be speaking on. Yeah, Nandini, please.
Yes, sir.
Yes, we will be speaking on first-line systemic therapy options and driver mutations negative lung cancer.
So, are the slides visible, sir?
Yes, you are.
Okay, so good evening, everyone. The topic given to me today is on first-line systemic therapy in driver mutation negative non-small cell lung cancer. Without wasting time, we'll start. In driver mutation negative non-small cell lung cancer, the treatment paradigm and the options have significantly improved over the past 2 decades. More than 20 years ago, treatment options were only limited to chemotherapy, which initially showed improvement over best supportive care. And the chemotherapy compounds that were commonly used were platinum-based doublets, which included cisplatin or carboplatin with another active cytotoxic agent, preferably for 4 to 6 cycles. And if the patient was a non-squamous and on pemetrexed, then pemetrexed maintenance. So like you can see here, these are all the chemotherapy options that were used in the past. Most of them are the category 1 recommendations, where they were doublets using carboplatin, cisplatin with other partner groups such as taxanes, pemetrexed, gemcitabine, or etoposide. We know that the individual partner for the platinum doesn't really change the overall survival. More or less all have similar overall survivals. And also there were some non-platinum based doublets that were used in the past. So these were the similar slides of the platinum based combination chemotherapy, which are not recommended we have gone beyond these regimens in the current guidelines, but in our country, often because of lack of access to immunotherapy, we are still using these. And these are some of the non-platinum based regimens that were used in the past. So when we use platinum-based chemotherapy, the important questions that were there previously were the use of platinum versus non-platinum-based regimens. There were multiple studies, and this is a meta-analysis which shows data from 17 trials, which compared the various regimens, and they saw that cisplatin-based regimens, but not carboplatin-based doublet regimens, were slightly better than the non-platinum-based doublets, and that is how platinum-based regimens were initially preferred. But we also know that in the palliative setting, administering cisplatin for patients who are not that fit with issues of toxicity and trying to maintain a good quality of life in this palliative subgroup is difficult. And some studies looked at the use of carboplatin instead of cisplatin for its better toxicity profile. And this is one of these studies that looked at it. They looked at 2 doses of cisplatin, 50 milligrams per meter square and 80 milligrams per meter square. And they looked at carboplatin AUC 6. And it was found that if you compare carboplatin AUC 6 in combination with gemcitabine, it was non-inferior to giving cisplatin at 80 milligrams per meter square. So by and large, a lot of the practice shifted to using a platinum doublet most of the time with carboplatin for ease of administration and safety. Then there were questions regarding the number of chemotherapy agents and why doublets are commonly used. In older studies, what they noted was the use of a doublet definitely improved response rates and survival as compared to single agents. But adding a third drug, although improved response rates, the impact of survival was inconsistent, and hence triplets are not the standard of care. So this is one of the meta-analysis which looked at these, looking at doublet versus single agent versus 3 agents. And like you can see here, the response rates are significantly improved with improvement in the absolute benefit. 2 versus 1 agent, there is an absolute benefit improvement at 1 year with 5%. But really using additional drugs beyond the doublet did not improve survival. So our common practice of using cytotoxic chemotherapy is 4 to 6 cycles followed by maintenance. Beyond using doublet beyond 4 to 6 cycles has no definite survival benefit and is not commonly practiced. But we must know, though I've not put the individual studies, we must know that with all the combinations that were studied in doublet combinations, either platinum based or non-platinum based, ultimately there was a ceiling in terms of survival. which was around 8 to 9 months, and we were not able to improve survival beyond that. This is what the situation was 15 to 20 years back. And this ECOG 1594 study compared various doublet chemotherapies in stage 3B and stage 4 advanced non-small cell lung cancer. And you can see almost overlapping curves with a median survival of approximately 8 months. And then we realized that in non-driver mutated non-small cell lung cancer, there was at that time an unmet need to improve outcomes. And outcomes were improved significantly with the introduction of chemotherapy. So now in the current era, these are the latest NCCN guidelines, where there is access without limitations of cost. Immunotherapy in combination with chemotherapy or a second immunotherapy agent, like was discussed in the previous session, has become the standard of care for patients who are fit in non-small cell lung cancer. Whether it is non-squamous or squamous, various immunotherapy agents have been used. Depending on the PD-L1 used as a biomarker, monotherapy as well as combination therapies have been incorporated into the treatment regimen in the current era. So this is not only for patients with very high PD-L1 positivity, that is more than 50% without actionable molecular drivers, where monotherapy is one of the recommended regimens, but also combination with immunotherapy or a second with chemotherapy is recommended based on the disease volume and other factors. But even in patients who have lower levels of PD-L1, immunotherapy plays a role. And now in an ideal situation, chemotherapy with immunotherapy is recommended in this group as well. So what are the factors we look at while making decisions in our day-to-day practice? Of course, the disease, the type of the disease, the volume and metastatic sites, and if any life-threatening metastases are present, which can significantly influence our decision for treatment. Other factors such as markers for immunotherapy, PD-L1 expression, tumor mutation burdens, and other mutations which might affect the efficacy of immunotherapy in these patients. Also, patient-related factors such as performance status, age, comorbidities, any contraindications to immunotherapy such as the presence of autoimmune diseases and smoking habits, and also concomitant medicines, especially steroids, since they can negatively impact efficacy of immunotherapy. So let's go through immunotherapy in this setting of first-line setting in driver mutation negative non-small cell lung cancer. Immunotherapy is now used as monotherapy in combination with chemotherapy and in combination with the second immune checkpoint inhibitor, as well as a triplet combination of a CTLA-4 anti-PD-1 and chemotherapy. So this is the current algorithm where we have stage 4 or stage 3 non-small cell lung cancer not suitable for local therapy. We rule out an oncogenic addiction, and we can look at it in two ways. One is we look at only immunotherapy-based regimens. We have to select our patients carefully for these, where we use it as monotherapy or immune combinations. And again, immunotherapy plus chemotherapy, where we now have evidence for all comers. So these are some of the important trials, a summary of them, which assessed immunotherapy and in this setting. So there are studies which looked at monotherapy, like the Keynote 24 and the Keynote 42. They looked at monotherapy pembrolizumab in comparison with the platinum doublet. And the selection of the population was slightly different. This selected a population with a higher PD-L1 expression, and this was with the lower PD-L1 expression. And this study, you can see that the magnitude of benefit with patients with higher PD-L1 expression was more. There are other immune checkpoint inhibitors such as atezolizumab and cemiplimab, which were also evaluated immune monotherapy versus platinum chemo doublet. And there are also combination therapies which were evaluated with platinum chemotherapy, immunotherapy plus chemotherapy checkpoints. And these are triplets where two types of immune checkpoint inhibitors with chemotherapy or just dual immune checkpoint inhibitors were compared to chemotherapy. So are biomarkers important for chemotherapy, immunotherapy in driver mutation negative non-small cell lung cancer? So like we can see that in studies where the biomarker positivity was higher, or they were the tumors were more with higher immune infiltration with immune cells, they did better. So in the Keynote 24, they took a population enriched with higher PD-L1 expression, Similarly, for the semiplimab study, they had a PDL1 expression of more than 50%. And you can see that the magnitude of benefit in these studies are higher than the studies where the PDL1 expressions, which the patients with lower PDL1 expressions were included. So we know that PDL1 is not a perfect biomarker at present, but it is one of the most at this time point. This is one of the most widely available and probably the most reliable biomarker that we have to guide with therapy. However, the interpretation and there might be new biomarkers that may come in the future. What about biomarkers for dual checkpoint inhibitors? So this is little less clear. PDL1 also has been used, TMB also has been used in this Checkmate 227 trial. Both PDL1 and TMB were used and responses in both these categories were assessed. So which is the best biomarker for predicting responses to dual checkpoint inhibitors is not clear. Also, the responses to the combination of dual checkpoint inhibitors was not, PDL1 was not really predictive with even patients with lower PDL1 or PDL1 of less than 1% showing response. So the issue of predictive biomarkers still remains and when we want to use dual checkpoint inhibitors. So this is the evidence for monotherapy, like I mentioned. So this was the Keynote 24 trial, one of the earliest trials to look at pembrolizumab monotherapy versus chemo. And like you can see, this had a progression-free survival was the primary endpoint, and it showed a significant benefit with the use of pembrolizumab. And most of the subgroups had an improvement, whether it was a squamous or a non-squamous histology, whether patients received pemetrexed or non-pemetrexed-based therapy, including smokers or non-smokers, and whether they, irrespective of the region they came from. If you look at the long-term overall survival, you can see that these patients continued to benefit with the use of pembrolizumab, the patients with more than 50%. And you can see that after progression, crossover was allowed and about 2/3 of the patients actually crossed over. But at 60 months, this is a 5-year overall survival update, still 31% of patients were alive as compared to only 16% in the control arm, that is the chemotherapy arm, showing the benefit of pembrolizumab in this subgroup. So again, Keynote 42 is another study which assessed pembrolizumab, but this assessed pembrolizumab in patients with lower PDL1, more than 1%. And this study also showed the benefit of PDL1, where they looked at PDL1 groups of more than 50% TPS, more than 20%, and more than 1%. And what they also saw is that in all these groups, there was a improvement in the survival with pembrolizumab as compared to chemo. And then this study also suggested that we may consider it in patients with lower TPS. These are two more studies using alternative atezolizumab and semiplimab. I'll just move in view of interest of time. Another interesting study that was presented in ESMO this year was the use of atezolizumab monotherapy in patients with not eligible for a platinum-containing regimen or a poor performance status or who are not as fit, where they included patients who were platinum ineligible because of a poor PS, that is a PS of 2 or 3, or they were elderly, more than 70 years of age with a lot of comorbidities where platinum was to be avoided. And they should not have had driver mutations, that is EGFR or ALK positive patients were excluded. So these patients either received atezolizumab as a single agent.
Hello, ma'am. Ma'am, kindly conclude your talk in 2 minutes, ma'am.
Okay. Or they received monotherapy, and atezolizumab again showed benefit over chemotherapy in a patient with poor performance status. So this is one of the factors that we can consider in case a patient has poor PS. So to quickly go to combination of anti-PDL1 with chemotherapy. So these are the various studies that have combined. The Keynote 189, IMpower 150, 130, 132 have looked at it. And this was the Keynote 189 study where it looked at advanced non-small cell squamous cell carcinoma. And the combination of chemotherapy and pembrolizumab was seen in all groups, that is less than 1 to 49, and more than 50%. And this combination of pembrolizumab with chemotherapy showed a consistent improvement in overall survival, irrespective of the PDL1 expression. And this study, again, this is the OS update for almost 50 months. And you can see that this is maintained. The benefit with the use of the combination is maintained, and there's a plateau here. And this gave us the evidence to use chemotherapy with immunotherapy in all patients, irrespective of the PD-L1 status. But again, here just to note that the magnitude of benefit and the plateauing is higher in patients who had higher TPS as compared to lower TPS, where you can see the survival keeps dropping as the time goes by. So the similar data there is in squamous cell carcinoma, the Keynote 407. Again, chemotherapy with pembrolizumab was evaluated, and it showed benefit in all patients, that is more than 1% as well as less than 1%, with a magnitude with higher checkpoint inhibitors. So I will just quickly go through dual checkpoint plus or minus chemotherapy, which has been discussed in detail in the previous talk. So Checkmate 227 and Checkmate 9LA evaluated the use of Nivo-Ipi combination. Checkmate 227 evaluated in combination with chemotherapy, and in patients who had PDL more than 1, they also compared it with nivolumab. And as you can see here, the combination did better in patients who had PDL1 more than 1% as compared to the Nivo chemo as well as the chemotherapy combination. In the PDL1 less than 1% also, the combination did better. The Checkmate 9LA had a different design. It used Nivo-Ipi with 2 cycles of chemotherapy and compared it to chemotherapy alone. And this was the overall survival in non-randomized patients. The triplet arm improved the combination, improved survival as compared to the chemotherapy arm, which was seen in all subgroups.
Nandini,
so just
please.
to conclude, so this is the algorithm that we use. If the patient had a PDL1 of less than 50, it's usually the combination therapy that we use, chemotherapy with immune checkpoint inhibitors. In patients more than 50%, immune checkpoint inhibitors can be used as a monotherapy with select patients where there's high disease volume where we can add chemotherapy. So with this, I'll conclude. So checkpoint inhibitors have improved outcomes. There are still challenges and unmet needs which we need to address. And there is a need to improve access to these therapies in all patients. Thank you.
Thank you, Dr. Nandini. Now we will take the questions in the next panel discussion, which will be moderated by Dr. Ullas Batra. He is a Senior Consultant Medical Oncology, Chief of Thoracic Medical Services, Rajiv Gandhi Cancer Institute and Research Center, Delhi. He will be moderating management of driver mutation negative metastatic NSCLC. Sir, over to you, sir.
Okay, hi. Can you please invite my panelists too?
Yes, sir. I invite your panelist for this session is Dr. Rishabh Kothari. He is a consultant medical oncologist and director of the Oncovin Cancer Center and Medical Oncology, National Cancer Institute, Nagpur. Dr. Nandini Menon, she is a consultant medical oncologist, Tata Memorial Medical Oncologist, HCG Cancer Center, Vadodara. Dr. Vipul Deshi, medical oncology, gold medal from the Institute Hospital Solapur, Cancer Center Solapur. And Dr. Vishal is a consultant medical oncologist, Cancer Hospital, Hyderabad.
I think, thank you. And all young Turks are there. I think you should have renamed this, Youngistan. I think the new T20 deserves, the new Indian cricket T20 team deserves youngsters like Rusha, Pinaki, Vipul, Nandini, Vishal.
Chief of Youth Brigade, sir. You are Chief of Youth Brigade. Huh?
Dr. Naresh Somani is still keeping his video on, in the hope that I will, get him into this thing. Sir, we'll need you as a coach, sir. Is it okay?
Yes, sir.
Okay. So before
if it is our last talk, I will be anywhere on this earth. I will be joining it.
Sir, thank you.
It's always a pleasure to listen you and to know the various facts and how to analyze the things. Yeah, thank you.
क्या हो गया सर आज क्यों so शाम से कोई मिला नहीं क्या सर नंदिनी इतना अच्छा टॉक दिया उससे पूछते ना सर वो बेबसोदिमा वाला क्वेश्चन मैं नहीं बताने वाला हूँ.
So that question is for Nandini only.
Yeah. So we will start with Nandini. Nandini, you can put on the video. पढ़ मत पता लगा पढ़ रही है बेबसोदिमा का डेटा ये पूरा बता भी देगी सर. Okay, so let's just go ahead with this. Initially, I was asked to moderate about management of non-small cell lung cancer, and when I yesterday said, "यार कि बता तो दो मतलब क्या discuss करना है," then Tara really told कि चलो आप ऐसा करो biomarker negative कर लो. अब because नंदिनी इतना अच्छा पढ़ा देना है कि हमको सब कुछ पता होगा.
सर क्या है लास्ट क्लास आपकी अधूरी रह गई थी सर ऋषभ के टाइम पे.
Okay. So my first reactions when I first talk about non-small cell lung cancer patient, and when a patient comes to us with an NGS report of no actionable mutation detected, my reactions are, well, that's not a very good sign, and these reactions used to be prior to the widespread availability of immunotherapy. So today, honestly, when a patient comes to me, you get the biopsy done, adenocarcinoma or squamous, and then you get the NGS report, and the patient comes to you with an NGS report saying, Dr. Saab, I have spent 30,000 rupees. Today, now this report has come. I don't know whether I should be happy or sad if the report is negative. So, it's almost like saying if your EGFR cross is negative and your PDL1 is 90%, and if you can afford immunotherapy, I don't know whether you should be happy or sad, and that is what we are going to discuss. My subsequent reaction on the same report is I'm confused now. It was very, very easy earlier. You tell EGFR positive, you'll be okay. But today, if I have a patient, or let us, known to in a family circle, what would I rather have? And somebody gets a lung cancer patient. What would I rather have? Would I rather have a patient to be a non-small cell lung cancer EGFR mutant 30% with a survival of 3 years, or an ALK positive with a survival maybe of 7-8 years, or an immunotherapy where after giving 2 years of treatment, you have a 32% chance of somebody getting cured? So I'm confused. I'm honestly very confused. And thankfully, this is not a sponsored session. Otherwise, you would have asked me to, MSU, and MSG would be very happy. BMS would be very happy on listening this comment. But I'm actually confused. This is one thing which really happened. A patient came and asked me, so Dr. Saab, biomarker nahi aaye hain, to acha hai na? I said, I don't know, yaar. I don't know what to say. So Nandini, I'll start with you. Biomarker negative report, NGS no actionable mutation. Happy, sad. What do you tell the patient?
So happy, just like how you said that it's you don't know how to react. So we would say that there is no biomarker, but we can try with chemo, and if they can afford immunotherapy.
So happy, sad for the patient. PDL1 85%, EGFR and NGS negative. Happy, sad for the patient. Affordability, yes.
Probably more sad than happy.
Probably more sad than happy. Okay, that's something which I was not expecting. Okay, Dr. Vishal, EGFR NGS negative, smoker 55, PDL1 85%. Happy, sad.
Yeah, if patient is affordable, I'll be very happy, sir.
Patient is affordable, MSD will be very happy. Okay. So one happy and one sad. Let me go to Rishabh.
Sir, would be happy provided patient is affording, as everyone is.
Would be happy provided patient is affording. Okay, fair enough. I mean, so happy affording or a trial or something is there. Dr. Vipul?
Let's say happy for the patient, confused for choosing which treatment, and maybe sad for his pocket.
That I will confuse you more, don't worry. That I'll confuse you more about which treatment will be given.
And sad for his pocket.
Sad for his pocket. But I mean, I was just thinking about lorlatinib, in which, and I'm sure Pfizer will not want to listen to this, or I have already told them, lorlatinib, in which the PFS is expected to be 50 months or something. 1 year of lorlatinib will cost you 1.2 lakh rupees per month. That comes to 18 lakh rupees. Into 4, I'm sure Pfizer is the one who's interrupting this talk for me. So 1 year treatment is 18 lakh rupees with lorlatinib or alectinib. Into 4 years at least is 72 lakh rupees. 1 year of Keytruda is 34 lakh rupees. 2 years of Keytruda, that's it. And 32% survival in PDL1, more than 50%. And this is just simple mathematics that I have been just doing. I mean, I just thought this question, but this is what I'm just doing. So I don't know. I mean, actually, I'm confused, but I would rather disagree with Nandini. I'm more happier than sad for the patient, because if you respond, you have a reasonable chance to probably get a cure. I mean, Keynote 24 and 42 will probably did show us a 32% chance if your PDL more than 50%. Dr. Somani and Dr. Tarachand, if I can get you in also.
So I will be sad for the patient. If we look at the compliance, we look at the side effect profile of the most of the TKI for the EGFR and L. And the data which you yourself are telling something like going like 4 years, 5 years, that if the actionable mutation is negative, I'm sad for the patient.
No, sir, but lorlatinib probably has more side effects than what a pembrolizumab has.
So lorlatinib, alectinib, for that matter, for discussion and for the whatever debate we can have on that, that is the one aspect. The toxicity profile is always different. Why to choose every time for every patient lorlatinib? And if you look at the EGFR treatment like osimertinib or
EGFR to rene do, the median survival is only 3 years. I mean, I just purposely got alectinib and this because the survival is more. No, I mean, I'm just, everybody has a point of opinion, but to me,
and that 3 years data is with the oral tablet.
There's a median OS, sir. That's okay. So one is oral medicine, one is the immunotherapy. So that's absolutely all right.
So your question was very clear for the patient. The patient will always be happy to take the oral treatment.
The patient will always. Can the organizer?
Yes, sir. And the beginning, usually we counsel patient. You may get a treatment, injection-free treatment if the report comes positive.
Yeah, true that. So I mean, the point here is my shoulders used to droop when I used to think about a NGS report negative. If the patient can afford, I am not so pessimistic right now. I mean, that is what I can now say. So neoadjuvant therapy in lung cancer, I don't think there is a. Can the organizers please ask to mute people who are there? Okay, there's some disturbance going on, but I don't think there's any shock in the role of immunotherapy in lung cancer. I have already wasted around 10-15 minutes in discussing this stupid point about whether you are happy or not happy. So I'm not going to discuss about this, but typically where do you use immunotherapy? Neoadjuvant, adjuvant, consolidation, first line, second line, small cell CA lung. We will talk about this later. So let's talk about this now. Let me now start with Dr. Pinaki, whom I didn't ask. So Dr. Pinaki, 55-year-old female, never smoker, stage 4 lung cancer, EGFR all-cross, all biomarkers negative, PD-L1 65%. Lung with proliferation with bony mets is what the PET scan shows. MRI brain is normal. So Dr. Pinaki.
So, sir, basically, yeah, please, sir.
Yeah. So
these are the options. Yeah.
And what will you not give?
So basically, sir, still if the patient is symptomatic, I would definitely give chemotherapy, and I would like to combine it with immunotherapy considering this PD-L1 is 65%. Generally, I go for a platinum doublet combination pem-carbo with pembrolizumab, sir.
Okay, so what you will give is probably pembro-pem-carbo, that is one.
Yeah.
What you will not give?
Maybe single agent nivolumab.
Okay, so you will give single agent. You can give pembro, you can give atezo. Single agent nivo you will not give. A very common last two options. Can I come to Dr. Vipul? Vipul, the last two options are nivolumab pem-carbo, atezo pem-carbo. And trust me, I get a lot of prescriptions of, I hope Roche is not listening, because atezo is the cheapest immunotherapy. And I do get a lot of prescription for second opinion regarding atezo pem-carb. It becomes real difficult, even with my level of communication skills and smiling, to tell the patient to take something else. Happy giving atezo pem-carb? What I'll tell you is, atezolizumab is equal to pembrolizumab in the second line. Atezolizumab is equal to pembrolizumab in the single agent probably in the first line. So pembro plus pem-carb is equal to atezo plus pem-carb. That's the definition which everybody is doing, and they're giving atezo pem-carb. Happy, sad, your take.
If you ask for an evidence, I hardly see any evidence. But if you ask for a logic, it does look like a logical thing to do.
Okay, so you may give that. Okay?
Yes, we can consider giving that.
You can consider.
As far as finances are concerned, both nivo and atezo can come at lower cost, somewhat lower cost. Yes.
Fantastic, Dr. Vishal. I'm putting you in a difficult position, Dr. Vishal. You are unmuted. You are muted. Sorry.
I would consider like even atezo pem-carb also.
Okay, so we have 2:0. Two people considering atezo pem-carbo. Yes, Pinaki says probably. Dr. Pinaki, what did you say? Yes or no?
No to single agent nivo.
But you can consider. So 3 yes for atezo pem-carbo and 3-0 at present right now. Okay, Dr. Nandini. If you're not giving, if you're not giving low dose atezolizumab or this thing over here.
No.
No. Okay, so we have 3 negative and 1, so 3 positive, 1 negative. But the point here is that 1 Tata is negative. So this will tilt the entire 1 vote counts for 10 votes over here probably. We will see if we can circumvent this. Rishabh?
Sir, I have not given. I would rather stick to Pembro Pem Carbo.
See, I told you, Tata effect. One Tata says negative, everything becomes negative. And with one female Nandini power coming over here, everything will come over there. Okay, Dr. Tarachand and then Dr. Somani.
Sir, actually, it is difficult to give in private practice without any evidence, a regimen. That's why I will not use Atizo with PAM carbo alone without bevacizumab. But yes,
it is your family person. Forget evidence. It is a family person. They will not boil a
yes, then I will go with the people that we can use as because we don't find any difference among these three usually add to add.
Okay, Dr. Somani, sir.
2 points to make comment here. If it is squamous cell, then no.
No, it's a non-squamous. इतना तो सर हमें भी आ गया है सर कि squamous और pembro नहीं वो pemetrexed से नहीं देना सर आप ऐसा ना करें.
And second thing, I would like to club it with the nab-paclitaxel rather than giving with the PEM.
No, my question is very specific, sir. I know you are circumventing because you want to give Atizo PEM carb of IM power 130. What I want you to know is Atizo PEM carb.
So no.
No. So I think so there is a trial which Roche doesn't want everybody to know. And that trial, I think, is either IM power 133, if my memory, or 132, one of these, which actually compared Atizo PEM carb versus PEM carb. And the HR was 0.87 in that. And there was not much of there was a slightly positive, but the thing was not overtly positive. I would, so whilst I do agree that that by and large the immunotherapies are same. But I think whether in private practice or whether not in private practice, we should avoid giving combinations which have not really shown a survival advantage. So my typical knowledge, my whatever little knowledge is, I would probably not give in the absence of that. What Dr. Somani said was right. IM power 130 was Atizo nab-paclitaxel carbo. Absolutely okay with doing that. I do see a lot of Atizo PEM carbs. I would request, to me, I would not give it to my family member. I will not give it to somebody else's family member. I would stick on to Pembro PEM carb. So I think everybody is right. We will not give Nivo PEM carb. We will not give single agent nivolumab. Just go ahead with this. There's some data. This is what I'm showing you. A single agent immunotherapy is Keynote 24 and IM power 110 empower for the single agent chemotherapy. Keynote 189 and 407 are the combination chemo immunotherapy. And if you can see over here, the best results are there with Keynote 24 and IM power 110, and obviously the combination chemo immuno arm. One of the most important things, I think Rishabh will remember in their seminar also we spoke about, people say if you're very overtly symptomatic, people will use a chemo immunotherapy. And if they are not very symptomatic, higher number of disease, they will use only immunotherapy. The data about the real world by and large says aisa nahi hai. The PFS and all are by and large equal. The only thing which makes a difference is if it's a non-smoker, then probably do an NGS and then do not use single agent immunotherapy. Although whatever small little experience of 40-50 patients that we have, single agent immunotherapy in my practice is also not doing that great. So probably I would now stick on to chemo immunotherapy and then going ahead with that. The problem that I am facing with chemo immunotherapy nowadays is a lot of my patients are getting, I think Nandini, because you will have more experience than this, are getting nephrotoxicity. A creatinine increase of 1.5, 1.6, 1.7, it is making difficult for people to get Pembro, pemetrexed for a long time. But these are small numbers that we have. Just 40-50 patients that we have on first line therapy. But there are a lot of people who are getting this thing. So what I'm seeing is by 8-9 cycle, I have to dissociate, stop pemetrexed and just put them on to pembrolizumab. Hopefully in another year or two, we will have some more data coming up over there. Just 2 slides more about Checkmate 227. Nobody said a double IO combination. But this was the data which showed it really works. A word of caution, another trial, ipilimumab was added to pembrolizumab, and in that there was no difference. So not a big favorite of doublet IO. only IIO without chemotherapy in a patient of PD-L1 more than 50% also. This trial was basically negative. So, I mean, this is what BMS must be asking, ki hua kya yahan pe? Now, this one goes to Nandini. Nandini, after 2 years of pembrolizumab, what do you do? Stop, continue. So patient with stage 4 lung cancer, single agent pembrolizumab or Keynote 189, what do you do after that?
So after 2 years of pembrolizumab, based on the patient's response, we would discuss with the patient that evidence in most in the study was only for 2 years. But if he has a CR, then probably discontinue, but with close monitoring, and explain to them that there's a possibility of disease recurring. If there's no CR, though there's no evidence, we may discuss with the patient if affording to continue.
Yeah. So what you are saying is right, but in the trial Keynote 24, 189 and 42, the pembrolizumab was given only for 2 years. I don't know about the first line because we have not yet reached over there. In the second line nivolumab, we had around 70, I think 80, 85 patients, out of which 10 people we stopped immunotherapy after 1 year or 2 years because of various reasons. Out of these 10 people at a various endpoint, and I'm going to present the data in another probably year once the data is more mature, 6 patients had a relapse. Out of this, again, we gave pembro. So people have given nivolumab, second line because of nivolumab was the only one which was approved, stopped, and then now pembrolizumab is approved. So now we have given them pembro, pem carbo or something, or pembro paclitaxel carbo if they were squamous, and out of all those patients, only one patient has not responded. So maybe there is a stopping line also, and I think it is very important to find out whether it's 1 year or 2 year. Like HERA trial did in breast cancer. 1 year versus 2 year, but right now it looks like 2 year is reasonably okay. Keep them under close observation, as Dr. Nandini very rightly said, and then monitor thing, but probably CTC or MRD is going to tell us. But the hope is there that even if they relapse, probably you can go ahead and give them immunotherapy once again and they will respond onto that. So that's a very, very comforting fact. And I think I will speak with Dr. Kumar and Nandini again. I think we should pool our data of people whom we have stopped and who have gotten the disease back again, and then what happened. So the long-term survivors, I mean, that will be a very niche group of people. We should pool our data and then take it from there. Now the easy one, 1 to 49%. Dr. Pinaki, I'll start with you once again. What will you not do? Same patient, lung with effusion with bone mets, MRI brain normal.
Yeah. Again, okay. I think single agent immunotherapy is not something to be done. Go for a combination of pembro, pem carbo. It's a adenocarcinoma, right? Or a
it's an adenocarcinoma.
Yeah, so pembro, pem carbo.
Okay, so you will not give a single agent pembro, atezo, nivo. Nandini just showed that ESMO 22 publication in which people who were unfit for that is what you showed, Dr. Nandini.
Single agent atezo,
Yes, sir.
Was better than chemotherapy in that. And what was the PS which was taken actually in that?
They took for the over 70 PS 0-1 with comorbidities, and otherwise PS more than 2 or more.
So either a PS 2 or more, because that is something which is very interesting. I mean, a PS of 2 is something which immunotherapy doesn't really work, but probably chemotherapy also doesn't work. So that is why the bar was lowered. It was like from Tata you come down to us, and then from us you go down. You can't go down lower than us. So probably it was us and comparison with somebody else. So that is why it happened. So maybe, you're right. A single agent, pembro, atezo, nivo is something which will not give. Although again, the Keynote 42 trial showed, and the US FDA approval is for Keytruda PD-L1 more than 1%. There the chemotherapy was similar to patients, pembro was similar to chemotherapy. But typically, I don't think we should be giving this drug in patients who are 1 to 49%. So we will just show you that. Now, there is where the most important thing, immunotherapy in PD-L1 less than 1. I'll ask you guys, I'll start with Dr. Vishal and then Vipul after that. So immunotherapy in PD-L1 less than 1, the first question is, will you give or not? And second question is, which one will you give?
Probably I'll give, sir. Even PD-L1 is less than 1%. Recent study has shown that the chemo work well, and probably I'll choose like chemoimmunotherapy
Okay, chemo.
Like,
You don't have to be so apologetic about it. Somebody will be happy. No, either BMS will be happy or MSD will be happy. Why are you bothered about that? Or maybe Roche will be happy. Something will be happy. Okay, so you will like to give a keynote 189 combination. Okay, Dr. Vipul.
Yes, I would like to consider chemoimmunotherapy options like either pembrolizumab with pemetrexed carboplatin or ABCB like Empower 150. Nivo EP in a PDL1 less than % I will not consider either as a doublet agent, double immunotherapy agent. Nivo EP with 2 cycles of chemo, maybe I think I will consider this. And chemotherapy followed by second line. This is also a good option.
So you will not consider CM227. BMS people have not been coming to you very much longer. The Vipul, I will tell BMS people to go and speak over there. Nandini, your take on Checkmate 227 in PDL1 less than 1%.
So Checkmate 227 has shown that in the less than 1%, there was a better the responses and outcomes. But so in practical day-to-day situation, our experience with Nivo EP in lung is much less than Pembro with chemotherapy. So what we use commonly would be Pembro chemo.
Okay, so what you use will be Keynote 189.
Yes, sir.
Okay, Dr. Pinaki.
All the options mentioned here are valid, though I think my preference would
So
also
at least
be
the
that
question
Keynote
paper is right.
189.
The examiner is right. The problem is with the people who are answering. Absolutely fine. Great, thank you. I can close the session now.
The first one, sir, Keynote
Tell me.
189. That would is what I would have done.
I think there is no right answer. And if you think you're in a much more horrible position, then just look at the person who has to do this job. So I think what I will do, Nandini, is not even looking at this way. How can you? Okay. So this is what the PDL1 less than 1% data is. There is a data about, so I would agree we will use Checkmate, either a Keynote 189 or 407. CM227 is not something which I will use. I would want to give 2 lines of chemotherapy. In fact, I would, stick my neck out and say PDL1 less than 1%, women, squamous cell carcinoma, plus minus brain mets. That is the only subgroup in which Checkmate 9LA regimen and people who do not want further chemotherapy may help. So a PDL1 less than 1%, squamous cell, with women, this is the only population in which it had really shown a great advantage. Toxicity is a concern with the Checkmate 9LA. That is something which we'll do. Otherwise, whether I will give PDL1 less than 1% immunotherapy, yes, I will do. What I tell my patients is your magnitude of benefit may not be as great as a PDL1 more than 50%, but finally you will get some benefit. That is what I normally tell them. Just last 1 or 2 slides about immunotherapy in adjuvant setting. Dr. Rishabh, ready or not? So you have a patient who is T2N2M0, PT2N2M0, 4 cycles of chemo done, PDL1 of 40%. Will you give immunotherapy or not?
Sir, I have started counseling such patients. We don't see in a huge numbers. So, but scientifically, it is convincing.
Okay, so just because I think before Garima tells me to close my talk in another 2 minutes, this was an Empower 01 study design, and this was basically saying that the benefit is more highest in people who have PDL1 more than 1%. Now, very, very nice. I'll show you some graphs over there. PDL1 more than 1% includes 2%, 40%, 80%, 90%. This is what PDL1 more than 1%, all randomized stage 2 to 3A when PDL1 was not taken, and this is 1B to 3A. Again, see here, they have done PDL1 more than 50%, more than 1%. More than 1% also includes 70-80. It also includes 20-30. So this was presented in 2021. Now, this is what was presented in 2022, I guess, this ESMO. And what you see over here, what I like to show Dr. Samani also here is, if you are PDL more than 1%, 0.71, more than 50%, 0.43. But if you are 1 to 49%, your HR is 0.95. So even though the label is saying PDL1 more than 1%, probably the benefit is driven mainly by the people who are PDL more than 50%. That brings me to another important question, and I think which is a very valid question in my mind. Even in the metastatic setting, in single agent PD-L1 more than 50%, we say single agent immunotherapy. Shouldn't we be subdividing and seeing whether it is 75%, 80% or 90%? Because in the data of Sepilimab, I think the Sepilimab study, they did show that people who are PD-L1 more than 90% are much more better. So more than 50% also includes 55%, also 95%. So probably there also the benefit is given more by people who have PD-L1 of 90 and 100%. But right now, the people whom I'm counseling for adjuvant immunotherapy is PD-L1 more than 50% and node positive disease. That was there. Just when you thought it was getting over, there was another study, and I knew PD-L1 more than 50. This was the Pearl study. This study turned the conventional wisdom on its head, but I just said. So atezolizumab works in people who are more than PD-L1 50%. This study showed in adjuvant pembrolizumab there was no benefit of immunotherapy in PD-L1 more than 50%. So we don't know what exactly is the one. But if I am using atezolizumab in the setting, I am using right now for the more than 50%. We will need some more.
So Dr. Ullas, sir, this is not 2 minutes, last 1 minute, sir.
This is not. I'm just going to finish it off. I'm not going to discuss about autoimmune disease. I am just going to say, I think it's getting better all the time. We are moving towards the hope, and thank you. So thank you, Tarunji. Bye-bye.
Thank you, sir.
Thank you, sir.
Thank you so very much, Dr. Ullas, sir, for, actually everyone is speechless, the kind of moderation is being done. So thank you so very much, Dr. Ullas, and all the esteemed panelists to be a part of.
I will always remember that Nandini ki talk ke liye tum logon ne mera आधा घंटा late किया था. I will remember this, Nandini, next time.
Thank you, sir. You are really the finisher of the evening of the conferences. And you taught a good immunotherapy session in lung cancer. And now this topic is finished because you did last.
Just joking, just joking.
You kept this in halfway. Okay, you left last time in halfway.
No worries,
so now it is finished. So the last session was on a small cell lung cancer is not possible because of some technical issues. So now this was the last session of this conference webinar of the 4 days, and I really thankful to all my faculties who are the speaker and panelists, and and the moderators, and really and especially Dr. Ullas Batra also, and for the wonderful sessions and wonderful talk and moderation. And I also really thankful to the pharma who sponsored this webinar. Because of this, we could make it smoothly. Pfizer, Lupin, Viatris, and Freshness Kavi, Novartis, Sun, and Merck, Biocon, Roche, Dr. Reddy's, AstraZeneca. Now, and also I'm thankful to the who finished this event in a smooth manner. So really thankful to all, and good night.
So before we say good night, a big thank you from the organizing team, my colleagues Geetika and Garima, and thank you so much, Dr. Tarachand, for giving this opportunity. Thank you. Stay safe, stay blessed. Enjoy your evening. Till then, for your Monday morning.